Namaste. I hope everyone is safe and in good health. A very good evening to one and all. I am Akanksha Anjani Kumar Prasad, the marketing lead for American Institute of Balance India. It's been 2 years since the establishment of AIB in India. In honor of the same, it gives me a great pleasure to welcome our distinguished speakers, panelists, attendees to today's Trination Webinar to get a deep dive into the world of vertigo and balance disorders. To begin with today's session, I would like to take you through a short presentation on the need for clinical skills for vestibular examination in India. Approximately 180 million people are seen to suffer from balance and dissonance disorders in India. This brings in the need to have a force of vestibular rehab specialists to cater to this need. This is where we, as a team at American Institute of Balance India, come into the picture. Our vision and mission is committed to provide consistent, high-quality, evidence-based care in balanced health to one and all, and providing professional development to practitioners throughout the world. We focus on three key things: education, patient care, and research. For education, we have our online International Vestibular Rehabilitation Certificate Course 1 and Certificate Course 2. For patient care, we have the AIB Center of Specialty Care and the Balanced Life branding license for the GPs. The research, we have access to AIB USA's library of 3,000 plus articles, to which 300 plus articles are added every year. Our courses include the access to all proprietary AIB clinical pathways and protocols. They give the access to online video demonstrations, tutorials, and FAQs on the international portal. Unlimited access to AIB articles and research papers, and the certificate and licensing fees in rupees is at a discounted rate. We also have a special discount for attendees of today's webinar, which we will be displaying at the end of today's event. For patient care, we have the AIB licensing program, which is known as the Center of Specialty Care, especially for the MS, MD, ENT, neurologists, otolaryngologists, and neuro-otologists. At AIB, we focus at offering you the opportunity to be a part of the highly effective clinical methods and globally recognized diagnostic treatments. With that, I begin today's event. Today, here we have the agenda for today's webinar, where we have the stalwarts from all across the world. To begin today's session, I would like to call upon Mr. Amrish Sahai, who's the SBU and the head for Sun Pharmaceuticals. He'll be talking for 2 minutes. Can I please have you on stage, sir?
Thank you, Akansha. Very good afternoon. I take this opportunity to welcome our each and every delegate. Today at this event, we have organized 20 centers wherein the program is going live. Few highlights about Sun Pharma. Sun Pharma is a company which started in 1983 with a capital of 10,000 rupees. And our last year's turnover happens to be 16,000 crore with a net profitability of close to 1,000 crore. Sun Pharma is a #1 company in 11 therapeutic segments, including cardiology, diabetology, neurology, psychiatry, neuropsychiatry, dermatology, gynecology, and ENT. We have 44 manufacturing sites. Sun Pharma became the #1 company in India 4 years back. And in prescriptions, we happens to be again a #1 company. Sun Pharma has been awarded as a global company with many R&D facilities, and all the brands, whatever are available in the market, whether India or international, are of world-class standards. Sun Pharma is a company which is highly academic, and virtually in all the ENT programs, whether it is Rhinocon, AOCon, or Assicon, and we are available and we are present. Besides this, we are present into many workshops, many surgical workshops as well. This is a very novel initiative which has been initiated by none else but Dr. Neha Srivastav. And I'm sure with today's presentation of our national as well as international speakers, all of you are going to be highly benefited. Thank you very much.
With that, Let me call upon our very first speaker, Dr. Sandeep Rajagopala. A surgeon of international repute, Dr. Sandeep did his MS ENT from LMT Medical College. He then worked in ENT, audiovestibular medicine, and general practice in the UK. For the last 4 years, he has worked as a vestibular physician in a private vestibular clinic in Canberra, Australia. Currently pursuing a PhD in pathophysiology of visually induced dizziness in vestibular migraine through Australian National University. Today, he is going to talk about Meniere disease. We will follow it up with a quick Q&A session based on the questions that you've already registered on our platform. Dr. Sandeep, the platform is all yours.
Thank you for that kind introduction. Let me share my screen first. Can you see the screen?
Not yet.
Okay, give me a second.
Sure. Yes, we can. You can put it on full screen mode.
Yeah.
Perfect. Thank you.
Thank you for AIB India to invite me to present this, and thank you to Dr. Neha Srivastava for especially in this regards. So my topic for today is Meniere's disease. Meniere's disease is around the third or fourth most common disease in my practice. It can be one of the most easy diagnoses with all the classical symptoms coming with all tick boxes, but it can also be very difficult to diagnose with numerous other symptoms which are more vague, intermingled with migraine symptoms, etc. We know that it's chronic illness with significant morbidity affecting the adult or working age, which makes the morbidity more worse. The diagnostic criteria has been put by Barani Society in 2015 in Journal of Vestibular Research. These include 4 criteria. Each has to be met. So 2 or more spontaneous episodes of vertigo, each lasting between 20 minutes to 12 hours. Audiometrically documented low to medium frequency sensory neural hearing loss in 1 year, defining the affected year on at least one occasion before, during, or after one of the episodes of vertigo. Fluctuating oral symptoms, which could be hearing, tinnitus, or fullness in the affected ear. The last one is to other vestibular diagnosis has been ruled out. So audiometry is similar like this. If the audiometry doesn't show a characteristic picture, then we call it probable MD, but other criteria are met. So pathology was first discovered in 1938 by Horpike and Keynes and Yamakawa independently. Endolymphatic hydrops is very much associated with Meniere's disease, and endolymphatic hydrops is distension of structures filled with endolymph. And these structures are cochlear duct, saccule, utricle, and ampulla in that order. A dilatation of the scala media of the cochlea happens. For example, this is a normal scala media with a resinous membrane. It is dilated and the resinous membrane is pushed into the scala vestibuli. In terms of vestibule, this is a normal structure with saccule and utricle. Saccules are generally smaller compared to utricle, but this ratio is reversed in endolymphatic hydrops in this specimen, where the saccules are quite a bit distended and almost occupying the whole of the vestibule, and the utricles are almost the size as normal. Underlying etiology of Meniere's disease is not completely understood, but endolymphatic hydrops doesn't all mean that you will have symptoms of Meniere's disease. So endolymphatic eye drops would be a final common pathway for a variety of inner ear insult, including viral infection, genetic predisposition, dietary factors, autoimmune abnormality, and allergic response. In terms of clinical features, adults around 40 to 60 years are the main patients we see. There is a slight female predominance. Typically, patient comes with a spontaneous onset, random, out of blue, severe vertigo attack, which are episodic, and the episodes comes around 6 to 11 per year in the initial few years. These have severe nausea, vomiting, and sometimes diarrhea and sweating with oral symptoms. And there will be a period of remission which can last for months or years, and then we can have a recurrence. Spinning is very important for the diagnosis. If the patient only has dizziness or imbalance, then other alternative diagnosis should be entertained. If you're seeing a patient when you have an acute attack, then you will have an irritative nystagmus towards the affected side initially, followed by a paralytic nystagmus towards the opposite side, and then a recurring nystagmus towards the affected side. And if you do a head impulse test or video head impulse test, it could be positive on the affected side. But these can become completely normal afterwards, after the attack, and in between the attacks, physical examinations are generally normal. So in terms of audiogram, typical audiogram would be a low-frequency sensory neural hearing loss based on bone conduction, which shows a loss of at least 30 decibel on two contiguous frequency below 2000 hertz. And later on, in advanced Meniere's disease, there will be a flat curve where all frequencies are affected. Imaging of Meniere's disease is the most exciting part now. This uses the phenomena that perilymphatic space, but not endolymphatic space, enhances with gadolinium. And we use special technique, mainly 3D flare technique, and with a powerful magnet. Gadolinium can be injected IV or through intratympanic route, but specificity is quite high and sensitivity is quite high to demonstrate endolymphatic eye drops. So this is to demonstrate Meniere's endolymphatic eye drops, which can suggest Meniere's. It also can rule out other disorders of inner ear and brain, and these are very important before invasive intervention. For example, a MRI scan here shows perilymphatic enhancement of the cochlea and the vestibule, but there is hardly any negative contrast seen because there is no endolymphatic eye drops, while in this, there is a negative contrast showing enlarged scala vestibuli, scala media in the cochlea, and the utricles are seen enlarged here, and saccules are seen enlarged, while the utricle is also seen enlarged. But the saccule is much more larger than the utricle, which is a reversal of the ratio. So this patient has grade 1 cochlear and vestibular endolymphatic eye drops. The most important development, which I think has happened, is this clinical practice guidelines, which has been published by American Academy of Otolaryngology and Head and Neck Surgery in 2020. There is so much of variation in treatment of Meniere's disease that a clinical guidelines by a large panel with multidisciplinary team was very essential. And before coming into their guidelines, just briefly going through the treatment options, there's no cure for MD. Management of conditions are helpful to managing the condition by helping to control the symptoms of what we are trying to achieve. The options are dietary restrictions, lifestyle changes, medications such as diuretics and beta-histine, hearing aids, and then invasive therapy if that doesn't work, with mid-layer injection with steroids and gentamicin. Surgical options are endolymphatic sac surgery, vestibular nerve section, and labyrinthectomy. So patients, according to the guideline, with patients with new onset of episodic vertigo, take a good history and physical examination, rule out other causes, especially take history of migraine. And if the patient has migraine, only follow that guidelines. if the patient also has migraine and Meniere's disease symptoms, offer vestibular suppressants to control acute vertigo, which could be prochlorperazine or benzodiazepine. My usual practice is to give lorazepam 1 milligram with ondansetron, which both can be taken sublingually, so that patient doesn't have to swallow. When as soon as possible, get an audiogram, and if it shows a asymmetrical hearing loss, then an MRI scan be offered to confirm endolymphatic eye drops if it's available in your area, or at least to rule out other things. But do not offer a electrocochleography or VAMP to diagnose Meniere's disease, as the specificity, the sensitivity is poor. And also do not offer positive pressure therapy like Meniere device, as there is no evidence for it, but offer education regarding Meniere's disease, offer diet and lifestyle modification. If the patient is having acute attacks, vestibular rehabilitation doesn't have any role, so do not offer. Diuretics and beta-histine has not a great evidence, but is supposed, we all offer it because it doesn't have a lot of side effect. And if the patient is still symptomatic, there is some evidence that intratympanic steroids may work, so it can be offered. And if the patient is again symptomatic afterwards, offer intratympanic gentamicin, which has the best evidence out of all the treatment. In spite of gentamicin, in very rare patients, if they're still symptomatic, then the management depends on a serviceable hearing. If they have a serviceable hearing, if they do not have a serviceable hearing, then labyrinthectomy can be offered as a definite management for stopping recurrent vertigo, but the patient will be left with a kind of a dead hearing and vestibular system on that side. If they have a serviceable hearing, it is much more complicated because vestibular nerve section and endolymphatic sac surgery both have controversial evidence. Luckily, many of the patients don't reach there at all. If they are hearing impaired, having a hearing rehabilitation by hearing aid is very important. And if they have chronic imbalance, offer vestibular rehab. So in terms of dietary restrictions, lifestyle changes, low sodium of 1,500 to 2,300 milligram with low alcohol, caffeine diet is recommended. Allergy management and stress management has some evidence. In terms of diuretics, thiazide with or without potassium sparing diuretic is used mostly. Diamox can be used, but in my experience, it is less tolerated. But be aware with both these to monitor kidney function, increase chance of gout, electrolyte imbalance will be there. The evidence is not great, but Cochrane systematic review showed some evidence, and these interventions doesn't have a lot of side effects. In terms of beta-histine, which we all use, the evidence is controversial, or mixed, not controversial, it's mixed. It's a histamine analog, has a strong antagonizing property with his H3 receptor, but a weak agonist with H1 receptor. Very interesting to know that FDA has not approved its use in Meniere's disease because of conflicting evidence. So in 2016, Cochrane systematic review showed that a pooled data around 30% greater rate of reduction in vertigo symptoms of all vertigo, including Meniere's disease, compared to placebo, with a number needed to treat of 5. But they recommended that we need a better randomized blinded study because of large amount of statistical and clinical heterogeneity. And in fact, this was done in 2016 called BMED study, where its double-blind RCT was done with placebo, low dose beta-histine and high-dose beta-histine was used in 3 arms. And it was found that significant decline in vertigo was found across all groups, but there was no significant difference between the 3 arms. So it was shown that high and low dose beta-histine was no better than placebo. Oral steroids, antivirals, and benzodiazepines have limited data. Intratympanic therapy is an optional. The vertigo control is between 31 to 90%. It is inferior compared to IV gentamicin, which has a vertigo control around 70 to 87%. But the hearing loss is very low, obviously, between 0 to 8% in steroids compared to 12.5 to 15.4%. Intratympanic gentamicin has the best evidence out of all of the interventions. The systematic review showed 27 studies with a almost complete vertigo control in 73.6% of patients. Another systematic review showed a vertigo control overall of 89% with a tinnitus reduction of 57%. But in this SR, a hearing worsening of 26% was found with a study range of 0 to 90%, which is a wide range. But the panel decided that it was a safe and effective treatment option for unilateral MD who failed conservative treatment, but should be cautious with bilateral MD. In terms of ablative therapy, it is very rare these patients will have this, but if you have a known serviceable hearing and patients having recurrent attacks and failed all the other treatments above, can be offered. And it can be considered in drop attacks, but even gentamicin can be used here according to new studies. So labyrinthectomy is less and less used. Vestibular nerve section is an option, but it is hardly used because gentamicin can be used as an alternative, and it has the same vertigo rate control as vestibular nerve section within 78 to 90%. But because vestibular nerve section is a intradural procedure, it has side effects of craniotomy, and it is risk for facial nerve and hearing loss. Well, endolymphatic sac is not recommended. Sac surgery is not recommended because of uncertain benefits and discordant result. I'm stopping there now, and I'm happy to take questions.
Thank you so much, Dr. Sandeep, for such an excellent presentation. I'll just quickly guide you through the questions. Some of them are live and some of them we've received on our online link.
Mm-hmm.
Yeah. Okay. Yeah. So first question, Mr. Jayaprakash from Surat has asked how to manage vertigo in Meniere's disease and what's the future of audiology?
Well, that's my presentation, isn't it? So, follow the guidelines. Sorry, I'm just going to share my thing. Can I share my...
Sure, yeah? Absolutely. Just give me a second. I'll just get that sorted for you.
Future of audiology.
Yeah, you can take over.
Okay, good. Look, I mean, this guidelines is open access. I would strongly recommend that we follow it. That is the way we should actually, because there is so much of discordant evidence. We have to follow some guidelines where they have actually munched upon all these evidence and gave us some way forward. Look, I'm not sure how to respond to the last question, actually. I'm sure that audiology has a very good future. If it's in regards to vestibular medicine, it has a great future, and it has been neglected throughout the world. And people like Professor Kathois and Professor Halmagi has actually put light on it, and there are patients who are really in distress, and this venture is excellent to promote this.
Thank you. I'll move on to the next question. Dr. Nitin from Mumbai wanted to understand vestibular neuritis versus labyrinthitis. I don't know if I spelled it right, because I hope I did. Yeah.
So vestibular neuronitis is where vestibular nerve is inflamed, most probably due to reactivation of herpes simplex virus. And it only affects the vestibular part of the labyrinth, while labyrinthitis is classically when both the cochlea part and the vestibule is affected together. And it could be various reasons. So it could be a arterial lesion, it could be a thrombus or a emboli, surgical damage which affects the artery, or it could be an infection coming from meningitis, from middle ear, or from other part, from the blood. So the hearing loss is the main reason to suspect if the patient has labyrinthitis or if the patient has neuronitis. So neuronitis classically only will be affecting the semicircular canals and possibly utricle and saccule, depending on whether it's pan-vestibular neuronitis. As you know, vestibular nerve is divided into two parts, the superior and the inferior. 85% of the inflammation happens in the superior, and mostly the inferior vestibular nerve is spared. So posterior semicircular canal and mostly saccules, utricles are spared, while in superior vestibular neuronitis, lateral and anterior is affected, and possibly the utricle is affected. So that's the difference.
Okay. The next question is Dr. Ashok from Kolkata, who seeks your advice on what are the latest investigations suggested for vertigo.
Then I'll just concentrate on Meniere's disease. Vertigo is such a big field. So as I suggested, I'm very excited about imaging in Meniere's disease. And in fact, I had at least 5 to 7 slides on imaging, which I had to remove. It is most exciting modality. There are times when we know that clinically we know that patient is affected by Meniere's disease, but the audiometry is not completely low frequency hearing, or there may be other signs. Patient is not improving with diuretics, etc. In those patients, having a demonstration of endolymphatic hydrops it would be great. So we can confirm that there is another tick box for Meniere's disease, and then we can do definite treatments, including IV intratympanic gentamicin. And I think the specificity and sensitivities are keep on increasing. It is. I don't have an access here in Canberra, and I'm trying to get my radiologists to do it. It's not that difficult to do it, and with IV gadolinium, it's quite easy to do. So I feel in 5 to 10 years, it could be part of the criteria for diagnosing Meniere's disease. Is my hunch.
Okay.
Sorry, I can't hear you.
Sorry, yeah. The next question is for Dr. Isma from Riyadh, Saudi Arabia. What are the latest treatments for Meniere disease? What's the dose for intratympanic steroid injection?
Right. So I got this question, and I have actually looked at what is the dose of So what is the latest treatment? I think, look, more and more evidence is coming that IV intratympanic gentamicin low dose could be something which would be the treatment of choice, because when everything fails, when the normal conservative management fails, steroids has still not a clear cut evidence, but low dose gentamicin seems to have the best benefit, and we may be able to just get away with 1 or 2 injections. So in terms of dose for IV, so intratympanic steroids, just give me a second, I prepared a slide for it. It is, it's a tough, though 2 steroids can be used, dexamethasone and methylprednisolone. Various doses are there in the studies, ranging from 0 to 24 milligram per ml, and methylprednisolone from 30 to 62 milligram per ml. And the milliliter volume is only 0.5 ml. So normally 4 injections are done within a period of 2 weeks. Here in Australia, we use 4 milligram per ml. So we can only inject 0.5 ml of that. So an injection would be, say, around 2 milligram per injection. Methylprednisolone in that case would be around 15 ml of some sort. There are various ways of injecting it, but the most common is by just using a syringe through the tympanic membrane, which seems to be the most common and most effective. Not effective, the effect is almost the same. Most common and more easier to use. And the other ways are tympanostomy tube and steroid drops, but there is higher chance of perforation. You can use round window microcatheter perfusion system, micro-wick, and these are all perhaps newer techniques, may not have much benefit and may have some increase in cost and increased chance of perforation. Newer modalities like hydrogel, IT drug delivery systems are coming, but look, the evidence for these are still not very, very great. So we need to watch and wait before we adopt this.
Okay, Dr. Sandeep, actually, we have 4 more questions. I'll just quickly run you through them, which we've been rushed with 15 questions actually now. We're just trying to sort it out. The next one is the role of Odenstron and Meniere's disease. Odenstron, sorry, I'm sorry.
Ondansetron?
Yes.
As I said, I use ondansetron as it is a medication for acute management of Meniere's disease. So it's sublingual and it's quite effective for improving nausea. I give around 4 milligram sublingual tablet or 8 milligram, depending on the patient. A patient is asked to keep it with them and take it if required, if they get an acute attack as soon as possible, so that their nausea is better, the vomiting will be controlled. I also, as I said, I'll also give lorazepam, we call it Ativan over here, which is a off-label use sublingually, but it also dissolves sublingually and reduces the symptoms significantly. So these are the 2 things which I use here. And ondansetron is very commonly used for nausea. But does it have anything to do with the pathology of Meniere's disease? I don't think so.
Right. The next question, doctor, is actually, what is the role of cochlear dialysis in MD?
Cochlear dialysis?
Yeah.
I don't know anything about it. I'm sorry for that.
All right. Okay. Just one last question. So basically, Dr. Tanu from Faridabad wants to know, she had a patient who was a sound engineer who came to her for treatment of vertigo and tinnitus, but everything is going well for the patient, but still the tinnitus sometimes occurs. If you could share any possible reason for that?
Well, I had another question regarding tinnitus, and I actually looked into the latest research. If I have 2 minutes?
Sure, of course.
Okay.
Of course.
Right. So this is the I had a question regarding tinnitus treatment raised to me. So I managed to have a rather than guessing, went to a review. I think it's 2019. Yeah. Tinnitus is produced by neuronal activity of central auditory pathway, causing a phantom sound in the absence of external stimuli, which is meaning hearing loss. So in that particular patient, there may be a hearing loss which may have improved or is still there. And these neuronal activity may be worsened due to stress response. So the tinnitus is a phantom sound. Okay, so only pharmacological treatment which has any effect is lidocaine IV infusion, which only has short-term reduction. Rest all the medications are not better than placebo. And most patients cope with counseling and explanation after ruling out any causes of tinnitus. But 10% unfortunately get frustrated because the symptoms and cognitive dysfunction is present and insomnia is present. So unfortunately, meta-analysis showed that none of these, including hearing aids, sound maskers, medications, antidepressants, supplements, hyperbaric oxygen therapy, acupuncture, neuromodulation, cognitive behavior therapy, did not change the tinnitus loudness compared to placebo. But out of all of those, CBT or cognitive behavior therapy had some beneficial effect on the quality of life, although the tinnitus loudness was still there. So I use CBT regularly for tinnitus. Just to mention, there is a preclinical trial with this medication, which is called AM101. It's an intratympanic injection and shows promise, and it is in stage 3 trial. So the evidence-based pharmacology is directed towards the comorbidity like depression, anxiety, and insomnia. So in that patient, tinnitus is a tough one. And when I see a patient with Meniere's disease, I tell them that there is a good chance that even if their vertigo and hearing loss is stabilized, the tinnitus will continue. And they can live with it. There doesn't cause any, you just have to counsel them properly.
If you don't mind, can I ask you one last question, because we still have 2 minutes for the Q&A. So what is an atypical Meniere disease is one repetitive question that we've been getting now.
Right here. So a typical Meniere's disease, you can say there are 2 types, which doesn't follow the classical picture. So there are times when there will be a delayed high drops, in a sense. So the patient have a sensorineural hearing loss in 1 year, few months or a year back, and they didn't had any Meniere's symptoms at that time of vertigo or ear fullness, but then they develop Meniere's disease symptoms with a continuous hearing loss, and hearing loss may not change, but they will have ear fullness and increase in tinnitus, and that is called atypical Meniere's. The other possibility is the reverse, where you have vertigo attacks without any ear symptoms or hearing loss. Or there may be some ear fullness, but the hearing loss comes only later, after, say, 4 or 5 attacks of vertigo. There is another concept of primary Meniere's and secondary Meniere's, where primary Meniere's, there is no other causes found. And secondary Meniere's are where you have autosclerosis, autoimmune disease of the body. There may be, there is a vestibular schwannoma, and then patient gets Meniere's disease in that year with or without treatment. So yeah, these are the concept. Atypical Meniere's is things which are perhaps not as clean as the normal triad will say.
Thank you so much, Dr. Sandeep, for such an excellent lecture, and thank you for joining us today. It's an absolute delight to have you, and thank you for catering to so many questions on the spot.
My pleasure.
If you don't mind, can I take over the screen? All right, thank you. Yeah.
You have, haven't you?
Yes, I have.
Good.
Yes, sorry for that. Minor technical glitches are a part of webinars, I feel. Okay, so thank you, Dr. Sandeep. We'll move on to our next speaker. Let me introduce you all to Dr. Mariam Melmpola. She's an associate professor of neurology at the Central Clinical School, University of Sydney. She's a neuro-otologist and director of clinical research at the Balance Clinic. She has been a consultant neurologist at the Institute of Clinical Neurosciences, Royal Prince Alfred Hospital. She's member of the Australian-New Zealand Association of Neurology, American Academy of Neurology, Royal Australasian College of Physicians, Neuro-Otology Society of Australia, and the Barani Society. Over to you, Doctor, for your lecture. I'll stop sharing so that you can share your screen.
Okay, thank you. Good morning, colleagues. Oh, it's good afternoon for you, isn't it?
Yes,
Let
it
me
is.
just share the screen. Now, how does that work? Lovely.
Yes, perfect. Thank you. I'll let you
So,
take over from here.
Lovely. Thank you so much for having me. So I was hoping today to talk to you about a subject that's really close to my heart. It's vestibular event monitoring, which actually refers to the technique of recording acute nystagmus that accompanies vertigo as the vertigo attack occurs, be it in the patient's own home, the emergency room, or general practice. And why is this so important? It is so because vertigo is associated with very distinctive nystagmus characteristics, which will often give us the answer as to the true origin of the cause. So this is a bit of a team effort, from the inventors to the implementers to the data scientists who crunch the data. And about 3 years ago, my colleagues and I undertook a proof of concept study where we looked at about 150 patients who'd been pre-classified. So we taught these patients to take home some mini video glasses invented by Professor Hamish McDougall, and they were taught how to record spontaneous, gaze-evoked, and positional nystagmus in their own homes. So these patients would sit up, record spontaneous nystagmus, then lie down and record positional nystagmus. The traces that the videos that were thus recorded were uploaded, and sometimes the patients returned them with these mini pairs of video goggles, and we were able to obtain some nystagmus traces and plot the nystagmus as a function of time in order to obtain our velocity profiles. So let me show you some real data. Here we have a patient who has an attack of left-sided Meniere's disease. On the top left-hand corner, we have the video. Down here, we have the nystagmus trace. Yellow for horizontal and blue for vertical. And as you can see, in the first minute or so of vertigo, this patient has quite high velocity, horizontal, left beating nystagmus, so ipsiversive nystagmus. But within a few seconds, the nystagmus direction begins to change, and now it's just downbeating. And very soon, it will completely change to right-beating nystagmus. So this pattern of first ipsiversive nystagmus followed by contraversive nystagmus we found to be highly suggestive of endolymphatic eye drops. And in fact, some of our colleagues who have used other techniques of event monitoring have demonstrated multiple direction changes during an attack of Meniere's disease. Now, contrast this against vestibular migraine, where people will also demonstrate horizontal nystagmus. Let me wait for the video to play for you. So, you will see horizontal nystagmus, which is of a much, much lower velocity. And the nystagmus enhances when they're lying down. So here we summarize these findings. In Meniere's disease, slow phase velocities are about 30 degrees per second. In vestibular migraine, it is about 1/10 of that. Also, as you know, vestibular migraine is a bit of a chameleon. So you will see horizontal, but also vertical nystagmus. And here is an example of primary position downbeating nystagmus. And in this next video, you will see primary position torsional upbeating nystagmus. So if we look at the velocities of these eye movements in vestibular migraine, I'd just like you to focus on the purple bars. The average slow phase velocity is about 5 degrees for vestibular migraine. But if we compare that against Meniere's disease, the average slow phase velocity is about 35 degrees. And look at the maximum slow phase velocity that we recorded in Meniere's. It was 160 degrees per second. So that's super fast. Many of our patients recorded about 25 attacks of vertigo. So we were able to see these direction changes in many, many patients. And our average timing for ictal ipsiversive nystagmus to change to contraversive was about 20 minutes. And for the second direction change was about 45 minutes. So in summary, the slow phase velocity of vestibular migraine nystagmus is very low. In Meniere's disease, it is high. The nystagmus direction in Meniere's disease is uniformly horizontal, but in vestibular migraine, it is quite diverse. Direction change is common in Meniere's disease and very rare in vestibular migraine. Using these attributes, we were able to separate these two important causes of vertigo with a sensitivity of about 95% and a specificity of 82%. Now, a few of our patients also had positional vertigo, and now in this context, it's really important to separate BPV positional vertigo from non-BPV central positional vertigo. Let me show you some examples that our patients recorded in their own homes. So here is a patient lying in the right lateral position, and she has a violent paroxysm of right-beating nystagmus. It rises to a very high velocity and then drops down to nothing. This is absolutely typical of horizontal canalithiasis. The next patient who also gets positional vertigo has vestibular migraine, and they will demonstrate low velocity horizontal positional nystagmus. So here we have in the primary position, not much to see, but with the right ear down, rather slow horizontal apogeotropic nystagmus. If we were to compare BPV with non-BPV, the most useful separator is the slow phase velocity profile, which is crescendo, decrescendo in BPV and rather flat in central positional vertigo. So we were able to use these attributes to separate these two conditions. Now, we also found a few recordings of rarer conditions. This lady was experiencing about 200 episodes of vertigo in the one day, each lasting about 5 seconds. And during each attack of vertigo, she would get very dizzy and have this little paroxysm of nystagmus that beats to the right. As you can see, her MRI scan demonstrated a very large petrous apex meningioma, and this is vestibular paroxysmia. So she responded to a minuscule dose of carbamazepine, and her vertigo came under control. In this second patient with vestibular paroxysmia, again, you will see a rather wild-looking paroxysm of nystagmus, lasting a few seconds, right-beating nystagmus. And when we did her vestibular function tests, we found that she had a deficit in her right horizontal canal. Here we have in red the head velocity when turning the head to the right, and in green the eye velocity, and this shower of refixation saccades or catch-up saccades indicative of a defective right horizontal vestibular ocular reflex. And on the left side you have a perfect left horizontal VOR. So this patient had a different course of vestibular paroxysmia. She had neurovascular compression of the 8th nerve complex, and she responded very well to decompressive surgery. So in summary, recurrent spontaneous vertigo can be recorded in the community, and we can separate vestibular migraine from Meniere's disease by the nystagmus velocity, direction, and tendency to reversal. Velocity is high in Meniere's disease, direction is always horizontal, and reversal is common. We were also able to separate episodic positional vertigo to BPV and non-BPV in the community by its velocity profile, which was crescendo decrescendo in BPV and flat velocity profile in central positional vertigo. So we found patient-initiated event monitoring to be feasible, and we found that it helped us to arrive upon a diagnosis much earlier than expected. So it seemed logical to extend this technique to the emergency room. And this is the recording device we use in the emergency room, a computer on wheels. We rather affectionately refer to it as the dizzy cow. And this was the research project of Dr. Benjamin Nam, one of my colleagues who undertook a PhD in my laboratory. He used 3 techniques: a structured history, event monitoring using video nystagmography, and when necessary, video head impulse testing as well. He studied 590 patients in the emergency room, and of these, 420 underwent his intervention. So I'd just like to share some of his data. In our emergency room cohort, 1/3 of our patients had acute vestibular syndrome, 1/3 came with recurrent spontaneous vertigo, and about a quarter had benign positional vertigo. Of those patients with acute vestibular syndrome, 1/3 had vestibular neuritis and about 1/3 had stroke. So let me share with you the ictal nystagmus characteristics of stroke. Now here in these pie charts, we demonstrate the nystagmus type, and in blue we show no nystagmus, in orange horizontal nystagmus, and then gray is vertical nystagmus. I'm sure you'll be surprised to find how many of our brainstem stroke patients demonstrated no nystagmus and how many of our cerebellar stroke patients demonstrated no nystagmus. This was quite a revelation to us. Also, the other surprising finding was that the most common nystagmus type in a brainstem stroke was not vertical nystagmus, but just simply low velocity horizontal nystagmus. So here's an example of nystagmus demonstrated in a patient with an AICA and a PICA stroke. We see primary position horizontal nystagmus, which you would be forgiven if you mistook it for peripheral. In contrast, vestibular neuritis has very distinctive characteristics. Nearly everyone had high velocity horizontal eye movements. A tiny proportion who had inferior vestibular neuritis had torsional downbeating nystagmus. So let me show you an example from the emergency room. Primary position left beating nystagmus in right horizontal vestibular neuritis. The nystagmus obeys Alexander's law. It is left beating no matter what, and it is fastest when looking in the direction of the quick phase. So, if we compare vestibular neuritis and stroke, nystagmus slow phase velocities are high in vestibular neuritis. Nystagmus direction is uniform and horizontal. In stroke, velocities were slightly lower. The nystagmus direction is quite diverse. The other difference is that gaze-evoked nystagmus is never found in vestibular neuritis, but it was found in about 30% of our strokes. So when we combine the nystagmus data and the video head impulse attributes, we were able to separate acute stroke from vestibular neuritis with a high sensitivity and specificity. And the characteristics that we used in the video head impulses were the head impulse gain, saccade prevalence, and the amplitude of the first saccade. The amplitude of the first saccade was about double in vestibular neuritis compared with stroke. Saccade prevalence was about double. The VOR gain was nearly normal in stroke, but about 0.4 on average in our vestibular neuritis patients. So in summary, when we used this intervention of a structured history, nystagmus recordings, and head impulses, we were able to help our patients in the emergency room to walk out with a diagnosis about 90% of the time. This is compared with the diagnostic rate of 30% in our standard emergency patients. So this means that if we use a history, event monitoring, and head impulse testing, we can increase the diagnostic rate in the emergency room by about 60%. And that's a huge difference. So our plans for the future are to extend this technique to primary care. This means that some of our very intrepid primary care physicians will borrow some of these video classes, learn how to use them, and record nystagmus in their own surgeries. This would be transmitted to a public clinic at the Royal Prince Alfred Hospital, where a researcher or a neurologist or an otolaryngologist would access the recorded nystagmus and guide the general practitioner on how to make a more accurate diagnosis. So I hope to talk to you about that next year, hopefully. And thank you for listening to my talk.
Thank you so much, Doctor. We'll start the question answer round. Mr. Jayprakash from Surat has asked how to manage vertigo in Meniere's disease and what's the future of audiology?
Okay, that's a very broad question. All right, let's start with the first question. How do we manage vertigo in Meniere's disease? So when I talk to my patients about the management, I divide it up into 3 parts: lifestyle management, acute management, and maintenance. The lifestyle management is really very important. And here in Australia, dietary salt restriction really plays a crucial role. I know that it's not all that popular, especially in Europe, but in Australia, we play a huge emphasis on dietary salt restriction, and it's correct that 90% of our patients are simply managed on salt restriction alone. We also emphasize on these patients getting adequate fluid intake because this is important as you diurese them. We also get them to ensure that they exercise regularly. With acute management, I often use a combination of 3 medications. 1, ondansetron, 4 or 8 milligram sublingual wafers. 2, a very gentle vestibular suppressant such as either prochlorperazine or cinnarizine for the mild attacks of vertigo. And then if the vertigo episode is really severe, we use a benzodiazepine. My chosen benzodiazepine is lorazepam. Then comes the maintenance therapy. Now, for the maintenance therapy, we use what Professor Bill Gibson has given to us as the Meniere's treatment ladder. This starts from the very low rung of salt restriction, going up to a combination of beta-histine and a gentle diuretic like dithiazide, going up to industrial doses of beta-histine, such as 9, 12, 16 tablets a day, and powerful diuretics like moduretic, so that's amiloride hydrochlorothiazide. Then the rung that's above that is the use of injectable drugs such as dexamethasone and intratympanic gentamicin, and the rung above that is ablative surgical therapies. I would say that a majority of about 90% of our patients are managed purely on salt restriction. About 10% of them at any given time are on medications, and only less than 1% would go on to ablative therapies.
Okay, so Dr. Kshitij from Delhi has asked, do you seek evidence of tinnitus, improvement on tinnitus, loudness only, or use scales such as THI? In which case, did the meta-analysis focus only on tinnitus loudness or also on THI?
Look, I don't, so from the tinnitus perspective, I don't research actively into tinnitus. So I'm only answering this question in the capacity of a clinician rather than a researcher. I do look after patients with tinnitus, and it's impossible not to if you look after Meniere's disease. There is a tinnitus severity questionnaire, but I have to confess I don't use it. I simply speak with the patient and ask them what their disability is. It is more, what I've found is that it seems to be more to do with how intrusive they find the symptom rather than the loudness, the perceived loudness of it. Some of them will tell me, oh my heavens, it's deafening, but I've turned it into my little friend. But there will be others who say, it's not all that loud, but it's just driving me around the bend. So it is a very subjective thing, but I have to be very honest and say I don't use any questionnaires. But there are some very active tinnitus researchers. One of them is Dr. Miriam Westcott in Melbourne, and she does tell me that she uses the tinnitus questionnaire and the dizziness and anxiety scale and the dizziness handicap scale.
So, doctor, how long and at what maximum dose we can give beta histidine to treat vertigo in Meniere's disease?
Truly, I don't think there is such a thing as a maximum dose. Every clinician has their comfort zone. So I would start thinking of ablative therapies if I have got to 48 milligrams TDS. But I do know that some of my European colleagues would be using about double that. I've been present when Michael Strupp has discussed his own management of Meniere's disease, and their doses are about double of what we would comfortably use in Sydney. But I think this is all what each clinician gets comfortable with. I believe it is entirely reasonable to use up to about 20 tablets of 16 milligram beta histine in one day. My problem with this is that the patient finds it extremely oppressive to take that many tablets. So when we get close to double figures, I would start taking steps towards a ablative therapy or at least intratympanic gentamicin.
Okay, doctor. So, Dr. Nitin from Mumbai wanted to understand vestibular neuritis versus labyrinthitis.
Okay. So vestibular neuritis refers to the viral infection of your vestibular nerve labyrinth. When we say labyrinthitis, we generally imply that there is hearing loss. In Australia, this is an incredibly rare occurrence to see an acute vestibular syndrome with full-blown unilateral vestibulopathy plus hearing loss. So, for example, I've worked in a public hospital with a very large vertigo clinic for the last 15 years, and I've seen neurolabyrinthitis about 3 times. So for us, it is quite rare, and they are so rare that you even remember the distinct clinical presentation. In my mind, there are 2 distinctive syndromes that are very different from each other. One is vestibular neuritis, where you predominantly have involvement of the superior vestibular nerve and 0 hearing loss. Then there is the other syndrome, which we don't typically call labyrinthitis. We call it sudden sensorineural hearing loss with vertigo. This one has profound hearing loss and only posterior semicircular canal dysfunction. Now, when that happens, it becomes impossible to find the true diagnosis. Because when we do detailed vestibular tests, all of these patients will have this posterior canal dysfunction and profound hearing loss. Some of them will actually be ischemic. So I feel it's a little bit worrying to call them labyrinthitis. So when I encounter these patients, I simply call them sudden sensorineural hearing loss with vertigo. Obviously, if they're a 20-year-old, you wouldn't treat them as ischemia. But as they cross the threshold of about 40 years, and as they start acquiring vascular risk factors, we are obliged to treat it as either viral labyrinthitis or an ischemic cause. So I would say I like to think of it as the separation of vestibular neuritis on the one hand and sudden sensorineural hearing loss with vertigo on the other.
Okay. So Dr. Sutikshan from Amritsar wants to know if there is a sudden acute true vertigo in a 67-year-old hypertensive diabetic female, what is the role of anti-thrombotic agents, dual or single, or LMWH? Low molecular weight heparin?
Okay. This depends very much on whether it is the first episode of vertigo. Okay. If, let's assume it is this lady's first ever episode of vertigo, if it is lasting a day or longer, then you automatically activate the HINTS protocol, right? You would examine their head impulse, their nystagmus, look for skew, and look for hearing loss. If, when you do all these tests, the head impulse is positive, there is no evidence of skew, the nystagmus is primary position, spontaneous horizontal nystagmus, that's unidirectional, and there is no hearing loss, well then, you can confidently diagnose vestibular neuritis and give them steroids and initiate rehab. If, however, they fail any one of these tests, so the head impulse is negative, there is skew, or the nystagmus is not unidirectional, or there is a hint of hearing loss, well, they've failed their HINTS test. And in that situation, yes, there is a role for antiplatelet therapy. Yeah. And the antiplatelet therapy will just give you the time to get that delayed MRI. But there are some instances when on the delayed MRI, you see nothing. You don't see a stroke. But regardless of that, if your clinical assessment said this is not vestibular neuritis, and it was a first ever long attack of vertigo, I would still treat them with antiplatelet therapy. Then you have the intermediate situation where you have this, not a whole day's vertigo, but a couple of hours. Now that is an acute transient vestibular syndrome. If that is a first ever attack, yes, you would investigate and treat with antiplatelet therapies because there's a high prevalence of ischemia in acute transient vestibular syndrome.
Okay, since we are running out of time, Doctor, one last question for you. Role of meditation and yoga as additional therapy for measure for MD?
For Meniere's disease, I think.
Yes.
I just think of my very wise colleague, Professor Bill Gibson, who used to say the first attack of Meniere's disease in many men and women was when their daughter acquired the first credit card. So stress has a huge role to play in triggering Meniere's disease. I would recommend yoga, meditation, and any intervention to relieve emotional stress. Thank you so much for having me. I think I've been talking too much.
No, thank you, Dr. Mariam. I think all of us can hear to your lecture for hours and hours because you have such a nice voice, especially. And I'm sure it's so informative to hear from you. Thank you so much for joining us.
Thank you very much indeed.
Okay. So, okay. So, moving on to our next speaker, it's my privilege to introduce you all to the man, the legend, Professor Ian Courtois. Professor Ian received his PhD from Monash University and was a Fulbright scholar at UCLA. In 2012, Barani Society awarded him Robert Barani Jubilee Gold Medal. In 2016, he was awarded the Gold Medal of the Prosper Meniere Society. The head impulse test of semicircular canal he developed with Michael Helmigi is used around the world and has been now realized by Hamish McDougall as the video head impulse test we hit. I would like to add on that especially it was a privilege that I got to meet him personally in Sydney, and he's such a gentleman in person too. Professor Courtois, without wasting, and thank you so much for that special coffee at University of Sydney. And you especially got us a chai latte, that's what I remember. So thank you, and thank you for waiting. And I'll let you take over from here. Thank you.
All right, I'll share my screen.
Sure, I'll just stop sharing. You can take over.
Okay. All right.
We can see your screen. Yeah, just full
Good.
screen.
All right.
Perfect.
I'd like to talk to you about these fairly new potentials, vestibular myogenic potentials, and to sound and vibration, and show you how they indicate dynamic otolith function. Realize I'm a scientist, I'm not a clinician, so I'm going to talk to you about the basis, the scientific basis of these myogenic potentials and relate them to what happens in the clinic. So, what are these vestibular myogenic potentials? This slide shows you. These are small potentials picked up by surface electrodes actually on the skin here, beneath the eyes or on the neck muscles here, the sternocleidomastoid over that, in response to sound and vibration. And when 500 hertz, brief bursts of 500 hertz tones are presented like this, a short time later, about 10 milliseconds, there is a small excitatory potential which is present, which is equal in both eyes. This is a very important aspect about VAMPs. We're looking for asymmetries in these potentials. And healthy people show these symmetrical, equal potentials, approximately equal potentials, in response to equal stimulation of both ears. This is the ocular VAMP. Up here is the ocular VAMP. And the VAMP that's recorded from the neck muscles is the cervical VAMP. As you can see, it's opposite polarity. This is an inhibitory response here. But once again, you can see the size of the potential is about equal on both SCMs in response to equal stimulation of both ears. But I emphasize its asymmetry of these potentials, which is so important. And these OVAMPs, as they're called, ocular VAMPs, to bone-conducted vibration or air-conducted sound, these ones indicate utricular function mainly, and these CVAMPs indicate saccular function mainly. Realize how valuable that is. All of a sudden, we've gone from having very crude tests of otolith function now to tests of utricular areas in each labyrinth and saccular areas in each labyrinth. This is a big step forward. And you can use air-conducted sound instead of bone-conducted vibration. But you have to be careful that the person does not have a conductive hearing loss, because that can attenuate the stimulus quite considerably. But the point I'm making is both sound and vibration generate both CVAMPs and OVAMPs. And the first question most people have got is, how do I know these VAMPs are really vestibular and not cochlear? Well, Jim Coldbatch solved that problem many years ago by showing that patients without hearing have VAMPs. They can't hear the stimulus, but the VAMPs are present. And conversely, patients with hearing but no vestibular function after systemic gentamicin do have VAMPs. So you led to quite clearly to the conclusion that VAMPs are vestibular, and in fact there are many thousands of papers since showing this. In 2008, we published data from 67 healthy people, superimposing the records for every one of them in response to that same brief 500 hertz stimulus. And you can see all of them show this small, it's only about 10 microvolts big, potential. The OVAMP here, this is to one stimulus, this is a different stimulus. And you can see, however, that patients without vestibular function after systemic gentamicin show nothing. VAMPs are vestibular, and I will show that they are otolithic indeed, not canal. What's the stimulus and how are they recorded? Well, the patient lying down is instructed to look upwards towards the top of their head. That is almost the most crucial part of the whole test. This device here is a mini shaker which delivers a stimulus to here, to the forehead. And we give the stimulus there because that causes about equal stimulation of both ears. And simultaneously, we measure both eyes with these surface electrodes here on the skin. Most importantly, the patient is looking up. And the stimulus is very short. It only lasts about 7 milliseconds, 500 hertz, bzz, bzz, bzz. And it's about as strong as a body massager. It's not particularly strong. It's very easy on the patient. It's very fast. And this test takes about 20 seconds. And of course, the data is averaged. For the CVAMP, the electrode is placed on the belly of the sternocleidomastoid, which must be tensed, because remember, this is an inhibitory potential we're looking at here, and the stimulus is delivered. And again, we're looking for the equality of the CVAMP response on the two sides. And this is the kind of result you get for a healthy person, as I've shown you already, these equal OVAMPs and equal CVAMPs. Healthy subject here, the key is the presence and the symmetry of those potentials. And a patient with complete unilateral vestibular loss. This is from a patient that had one vestibular nerve sectioned for removal of schwannoma, and you can see there is complete asymmetry. Now you get a very nice potential beneath one eye and nothing beneath the other eye. I point out to you one quirk about these OVAMPs is that they are crossed. So this potential beneath the right eye is indicating that the left labyrinth is in functioning normally. So OVAMPs are a crossed response, CVAMPs are an uncrossed response. And of course, we have calculated the asymmetry ratio very much like what people have done for caloric nystagmus and quantify that. But think about it. You can record these VAMPs and test otolith function in your clinic tomorrow, because you've got an audiometer, you've got an ABR averager. The only difference really between this and ABR is where you put the electrodes and the exact stimulus you're using. And so you have the facilities right there. But so much of the puzzle about these VAMPs is revolved around the mechanism by which sound and vibration can manage to activate otolithic receptors. That is resolved if you look at the anatomy and then the physiology, as I will show you now. This beautiful new figure from Christopher Smith, one of my students, shows you an enlarged version of the human labyrinth. Here is the footplate of the stapes right here, and this is the correct anatomical orientation in the skull. Directly opposite the footplate of the stapes is the saccular macula, a sheet of receptors here, and directly above the footplate of the stapes is the utricular macula, another sheet of receptors. So that's where they are. And in fact, this is what they look like. This is a guinea pig, and this is the whole otolithic, the whole utricular macula of the guinea pig covered by these white otoconia. This is 1 millimeter scale size. And of course, all of us have learnt that in fact, this otoliths operate by the receptor cells beneath those otoconia being deflected by gravity. So when the head is tilted to the right, gravity acts on the otoconia, deflects the cilia, and the person experiences head tilt, and it generates responses. This, of course, is true. That is absolutely true. It's just only a very small part of how the otoliths work. Because in the last 15 years or so, how they work has become much clearer, and the otoliths are much more sophisticated than this simple idea shows you. We need to look more carefully beneath those otoconia and look at the receptor hair cells. But one of the things I want you to realize is this proximity. I've shown you already. This is, in fact, a human stapes. We've done micro-CT on temporal bones and removed all the other bone apart from the stapes and the utricular macula and the saccular macula to show you how close the footplate of the stapes is to the utricular macula and the saccular macula. This little cube down here is 1 millimeter on a side. And you can see it is extremely close. Think about that as the stapes is pumping in and out during a normal stimulus. In fact, those fluid waves, pressure waves from the footplate of the stapes are impinging on these receptors on the utricular and the saccular macula. And I point out to you one other important fact, and that is receptors, vestibular receptors, are exquisitely sensitive, exquisitely. Deflections of those hair bundles of 10 to 20 nanometers, not micrometers, nanometers are enough to activate these receptors. So we've got a situation where this very large stapes footplate is generating these fluid pressure waves. And just to show you that this is not some trickery due to micro-CT, this is from Shuknik, showing you the footplate of the stapes here, and here is us right through the section of the utricular macula. One other important fact is that the utricular macula floats on fluid. It is not attached to bone. So here, very close to the footplate, we've got this floating structure with these extremely sensitive receptors sitting on it. It's almost designed to pick up sound and vibration, and it does that extremely well, as I will show you. So this looks like it's solid. In fact, here, all of that is floating on fluid. The only part of the macula which is attached to bone is here where the nerve leaves the macula. If we look straight down on a whole utricular macula, this beautiful reconstruction from Watanuki and Meisel Gottersberg in 1967, you can see each one of these dots is in fact a receptor. But as you look at it, obviously there's a band here which is particularly different. That band is called the striola, and it is made up largely of these very special type 1 receptors. These are fast, very important receptors that are enveloped by a calyx. The afferent fiber envelops the whole receptor. And this is the source of current, great interest in current research, how this amazing system works. So that striola then, in fact, divides each macula because the receptors, and there are about 30,000 of them on each macula, are pointed in opposite directions. These ones here are pointed outwards, those ones here are pointed inwards, and the striola is the dividing line. That striola is key for sound and vibration because it's receptors at that striola, as I will show you, which are particularly selectively sensitive to sound and vibration. We've gone from simplified diagrams like this, where all the receptors project into an otolithic membrane and it's a highly uniform structure. That is simply false. That is wrong, right? There's certainly two types of receptors, but they vary considerably across the macula. So at the striola, those receptors are short. These are the actual cilia projecting up above the macula. And just outside the striola, you can see these cilia project high up into the otolithic membrane. Here they don't. This idea that the macula is a uniform structure is just false. We're so used to thinking of these, focusing so much on the otoconia, we forget that the really important structures are the receptor cells themselves. These otoconia, by the way, with which you're all very familiar, in fact, special because they've got a very high specific gravity. These got the same specific gravity as granite. Otoconia really are effectively little particles of granite inside the labyrinth. So you can see why they do so much damage when they are dislodged. One other important aspect of that striola that I've mentioned is that the receptors there are not tightly attached to the otolithic membrane. Way back in 1968, H.H. Lindemann showed that they project into this cavity within the otolithic membrane. In other words, there's fluid there. So that fluid flow generated by the stapes can deflect those cilia of these very sensitive special type 1 receptors there. And you can even see in a broad, beautiful view of a scanning EM from Hunter Duvar, there is this recess here corresponding to the striola. Well, how do I know that these really do respond to sound and vibration? Well, I recorded from single nerve cells in anaesthetised guinea pigs, primary afferents, delivering many stimuli to identify whether canal stimuli respond to sound and vibration or otoliths, and also tracing back from neurons which are activated, tracing back to find out whereabouts they actually originated from, injecting a dye and tracing back. And most neurons are like this. This is action potentials in one neuron. As you can see, you can deliver vibration, quite intense vibration, intense sound, and you get nothing. Most neurons are like that, but some are not. Some, when you deliver a very small stimulus, you get a big increase in firing rate during the stimulus, be it vibration or sound. And these are vestibular afferents responding to sound and vibration. Canal afferents don't, but irregular vestibular afferents, afferents with irregular resting discharge, about 80% of them do respond. And we trace them back to the striola. So this region, this band that I've shown you here, is where these sound and vibration sensitive neurons originate from, here. Think about it. When you're delivering sound and vibration and measuring VAMPs, you're not just measuring the whole function of the whole otoliths, you're measuring the function of a very specialized band within that. And it's the very band you want to measure because those type 1 receptors are the ones which are most sensitive to ototoxic antibiotics. Histology shows these are the first to go. So when you're delivering ablative gentamicin for treatment of Meniere's disease, VAMPs are an extremely good way to monitor what is happening. But the overall message I want you to take away from my talk today is the realization that from each macula, from each utricular and saccular macula, there are two parallel streams of information about sustained stimuli like tilts and a system which is sensitive to transients. And this shows you beautifully. It's like a replotting of what I've shown you before. These are irregular neurons to increasing stimulus, and you can see a tiny increase in stimulus gives you a big increase in firing for all of these neurons. These are the transient systems. But what happens with the other systems, like regular neurons? You can increase the stimulus enormously, and they do nothing. These are the guys that are sensitive to tilts. These are the guys sensitive to sound. Does it cause eye movements? Yes, it does. We know that from Suzuki. Stimulation of the utricular macula causes activation of the contralateral inferior oblique. It also causes eye movements. Sound causes eye movements in guinea pigs, as you can see here, and also in humans. Very small eye movements, but present a stimulus, and you get these systematic eye movements. Each line is a different stimulus in horizontal, vertical, and torsional movements of the eye. So that projection, we think, is going from the utricle over the vestibular nucleus up to the opposite inferior oblique, which is where those OVAMPs are measured, but also inhibitory projections down to the ipsilateral sternocleidomastoid muscle. So the key message that I want you to remember is these two systems, sustained and transient systems. And it's the transient system which is activated by sound and vibration. And the old method of trying to diagnose otolith function by measuring counter-rolling, I must point out, does not work. Or rather, it works in acute patients, but a chronic patient does not. Counter-rolling means that when you tilt the head over, the eyes roll back in the head just a little bit. But in fact, it's very difficult to measure, and it does not identify this affected sign. The clinical value of VAMPs lies in identifying otolith loss, utricular, saccular, dehiscence, monitoring gentamicin, and together with VHIT, these allow objective measurements of the function of every vestibular sense organ. That is their true value. Neuritis, superior neuritis, and also they're very valuable for identifying SCD. If a patient's got a dehiscence of the anterior canal, then you get a superior canal, then you get these very, very large OVAMP responses in comparison to a healthy person. And what we're now finding is that some patients who've got isolated utricular loss, just like that. And those are regular neurons from the striola, the ones most likely to respond to sound and vibration, and they're the ones most vulnerable to damage by ototoxic antibiotics. This response of vestibular neurons to sound and vibration has been known for a long time. Goldberg and Fernandez published that in 1977, and we've simply enlarged upon it in many papers since. So VAMPs have become a very simple, fast, useful test of otolith function, and they work because they measure otolith transient responses. Thank you for listening.
Thank you so much, Professor. I have a couple of questions for you.
Yes.
I'll begin with the first one. What can be the reason for absent VAMP response in post-stapedotomy patients, even after successful airborne gap closure?
Could you just repeat that? I didn't catch that.
Absolutely. I think I even misspelled it, but I'll just repeat it for you. What can be the reason for absent VAMP response in post-stapedotomy patients, even after successful airborne gap closure?
Oh, I can't. There are probably many reasons. I've shown you how close the macula are to the stapes. So if you're going to put a hole in the stapes, you're very, very close to the utricular macula. And in fact, it's highly likely that the piston that you're going to put through this foot plate of the stapes may well damage or interfere with the actual utricular receptors.
The next question is by Dr. Sani, who wanted to know how to use CVAMP without EMG rectification or normalization.
This is a technical question. Jim Colbatch doesn't like the use of just simple recording, because the size of the response, particularly for an inhibitory response, depends on how tensed the muscle is. So he's devised this method of normalization. In fact, many people use that, but many people still use what I've shown you right through here, and that is the simple raw data where you are not normalized at all.
Okay. Dr. Ranjit from Chennai has inquired a little bit about the hint examination.
Well, you've heard a lot about that from Miriam. I don't need to go into that really. It's simply patients coming to the emergency room. If you test their head impulse response with our V-HIT system and they've got a normal response there, then it's more likely that they have had a stroke rather than vestibular neuritis. So dizziness can arise from both of those causes, and hints is a way of discriminating. And you saw how successful Dr. Miriam Welgenpoler's system is for discriminating between those two. It's an extremely important discrimination to make.
We have one last question. Dr. Kumaran from Bangalore wants to know about vestibular tests that are efficient for both clinician and patient.
Vestibular
tests that are efficient for both clinician and patient.
I still didn't catch it. Could you please repeat the question?
Sure. Dr. Kumaran for Bangalore wants to know about vestibular tests that are efficient for both clinician and patients.
Well, just what I've been talking about.
Okay.
Exactly. V-HIT is an extremely efficient test because it's done in about 10 minutes. And VAMPs are very efficient as well because they're done in about another 10 minutes or so. The longest part is putting the electrodes on. The whole emphasis now on vestibular objective testing is to come up with fast, efficient tests. And I've just focused on VAMPs being two of the fastest and most efficient of all of them, giving you objective measures of the function of these structures in the inner ear, even down to parts of the macula themselves.
Thank you so much, Professor Korthois. Actually, we do have a lot of questions, but it's too late in Sydney. So we'll probably email it to you. And if you find time, whenever you have, you can respond back to us with that and we'll forward that to the doctors. Thank you so much.
I'll just answer one quickly. Sure. Somebody asked about SC, why dehiscence is more frequent in the anterior canal. This is a dissection I did about 40 years ago. And you can see the bony covering here in the anterior canal is thick. But it's this bone which is missing, right? And the anterior canal is very close to the rest of the bony casing of the skull, whereas the other canals, in fact, are very well supported and covered by bone. So that's why it's more frequent in the anterior canal than others. So I'll now stop sharing and you can take over.
Thank you so much, Professor Korthois. Thank you. Have a good night.
Thank you.
I would like to express thanks to all our Australian panelists who have joined us so late at night. And thank you, Dr. Mariam, Dr. Sandeep, and especially Professor Ian Korthois for joining us so late. And we will be moving on to our session 2 now. We'll be having a short break for 3 minutes, and then we'll move on to our next session. Thank you.
A very good evening to one and all. I am Dr. Shilpi Saxena, and I am a part of the American Institute of Balance, India's advisory board. I will be taking you through the rest of the event. Our next speaker is Dr. Richard Gans. He is the founder of Executive Director of American Institute of Balance, PhD from the Ohio State University in Auditory Vestibular Physiology and Neuropsychology, leader in the development of vestibular evaluation and rehabilitation techniques, research scientist, member of American Academy of Otolaryngology, head and neck surgery, and the American Academy of Neurology.
Hello, everyone, and greetings from the American Institute of Balance in the United States. It's my pleasure to be a part of this important webinar between the United States, India, and Australia. I would like to thank Dr. Neha Srivastava and her excellent team at AIB India for coordinating this important program. Although many individuals will say that they're not used to seeing children with vestibular balance difficulties, the reality of it is that it's not as rare as you would think. There are a number of causations of vestibular and balance-related problems: migraine, otitis media, trauma, congenital, and syndromes and non-syndromal and mitochondrial factors. We're going to dive into some of these and talk about how to evaluate these children. As I often say, you can pick your friends, but you can't pick your parents. There are over 500 syndromes, non-syndromes, mitochondrial disorders that can affect the audiovestibular system. And again, this is not just for children with sensorineural hearing loss, although the prevalence of vestibular dysfunction is much greater in children with congenital sensorineural hearing loss. It can affect all children. In fact, vestibular expressivity is far more common in many of these genetic factors than hearing loss. And vestibular dysfunction without hearing loss may often go undiagnosed for many years. Now, what we're going to speak about a little greater depth is actually migraine. Migraine can be best described as a genetic neurological disorder. And as you can see in the blue box, there are 6 main categories of migraine according to the International Headache Society migraine classification. But within these 6, there's a total of about 23 subsets, so that migraine may or may not have headache. Migraine may or may not have an associated aura. But migraine is a lifelong condition and can be seen in infants at a very young age. In fact, BPV of childhood or infancy is benign paroxysmal vertigo of childhood. This has nothing to do with otoconia or the need for positional vertigo, canalith repositioning. It is, in fact, the most common cause of pediatric dizziness, accounting for up to 35%. Now, we say it's paroxysmal because it's an acute onset. Also, it may be accompanied by a torticollis, which is an ipsilateral contraction of the sternocleidomastoid muscle. So the child will have a lateral flexion in their neck. They may also have periodic vomiting, and it may be with or without headache, but it usually will also have a wide variety of patterns of nystagmus. Now, why would you have different patterns of nystagmus? Because more than likely is affecting either the peripheral or more likely the central aspects of the vestibular system. So this may affect the vestibulocerebellum. You also will have vestibular autonomic responses, and that's why the vomiting. But again, another form of migraine is actually cyclic vomiting syndrome. So you have to see if the child's vomiting is occurring only with these episodes of staggering, dizziness, ataxic gait, or if they have patterns of cyclic vomiting that actually has nothing to do with these other episodes. That in and of itself is another form of pediatric migraine. The onset of this condition is usually between 1 to 4 years of age. The earliest we've seen might be as young as 9 or 10 months. Please understand this is an absolute migraine variant, but since there is no specific test, it's really almost a diagnosis of exclusion. These episodes or attacks are brief, but may occur weekly or various times during the month. As I've mentioned earlier, you may look for vomiting, dizziness, vertigo, staggering with ataxia, different forms of nystagmus, and it may or may not have the torticollis, which is again the contraction of the sternocleidomastoid muscle. Now, what we see is as these children progress into adolescence, particularly around puberty, 30 to 50% of these children that did have BPV of infancy will evolve into full-blown migraineurs, very often with headache as well as other auras. Auras can be described as changes in vision, hearing, hypersensitivity to sound, smell, and we also see that there's a fairly significant number of them that also will evolve to Meniere's later in life. In childhood, though, most after a few minutes of these episodes will recover spontaneously. If they do have torticollis, however, they will require physical therapy with massage and stretching of the torticollis. This will not recover, but the nystagmus, vomiting, vertigo during this short-lived episode will. One of the things that we must be aware of is puberty onset. Now, we know that 1 out of 4 migraineurs are female, 1 out of 6 male. But we're seeing worldwide young girls entering puberty at a younger age. There are some theories that this might be due to early onset puberty due to steroids, hormones, antibiotics that occur in food products, milk, chicken, and the food source that the child is eating. Vertigo is the number one aura. It's going to occur in anywhere from a quarter to a third of these youngsters. Hearing loss is rare, but it can be fluctuant. But interestingly, unlike, say, Meniere's disease affecting the low frequencies, it may more likely affect the higher frequencies. Tinnitus, phonophobia, hypersensitivity to sound, also referred to as misophonia, dislike of loud sounds may also occur. The child may say they have trouble concentrating, trouble reading, and this may be because of some degree of oscillopsia as a side effect. So the question is, what is the best way to test babies and young children? Well, we know that the assessment process should always include the three primary reflexes: vestibular ocular, vestibular spinal, and vestibular colic. Now, each of the assessment techniques should be age appropriate based on the maturational development. It will be child directed. We're not going to be able to force the child to do anything. And we're going to use a combination of both behavioral clinical assessment and electrophysiologic evaluation. I'm going to show you some videos of some actual infants. This is a 14-month-old little girl. You'll also notice she has a kind of a right head tilt or flexion. This is a recovering torticollis. What I'm going to do in the next several videos is use some behavioral milestones to see if her vestibular systems are working properly and have not been adversely affected by the migraines. Now, what you're going to see is we use a play technique. Children love this. I'm going to lift her in the air and watch her legs. See how they come down and hit the ground very strongly, definitively, and she enjoys it as well. So it's a beautiful thing. She's very happy. A child without vestibular function or damaged vestibular function, when you landed them, their legs would curl up. They wouldn't have that nice solid grounding. Watch again. Nice solid grounding. And again, we make it fun. The parents are in the room watching as we go through the activities. Now I'm going to actually do what we call flying the child. Watch her back legs. This is called the Landau reflex. Look at her legs. See them kick up? That's a Landau reflex. And the children actually like this. See the legs kick up again. See the legs kick, and this is her gravity response. Now I'm going to put her on a physio ball, and we're going to play another little game. Notice how she immediately comes up. She was in the prone position. There she is flying, having a lot of fun. Legs are kicking up. Here she is on the physio ball. Notice her head is up and she's in a prone position. I did not put her like that. That is a normal reflex for a child with intact normal vestibular function. Again, we make a game out of it. We make it dynamic, and she's able to have a lot of fun. The beauty of this is we don't need expensive equipment, and we can do it in a safe, comfortable environment with very little expense. This is the same little girl. Now we're going to do cervical vamp. Cervical vamp, if you have the equipment, is the test to do with infants. And it can be done, it's very easy and simple, and it could be done in infants as young as 3 months of age. Why 3 months of age? Because the neck musculature is sufficient. We want to put the child in a position, because remember, the C-VAMP is an off response. The ocular VAMP is an on response. So we want to put the sternocleidomastoid muscle into contraction. And there, she's very happy. We can even do C-VAMPs with deaf children. The only thing we cannot have is a conductive loss. So we need to make sure that we've done otoscopy and we have normal tympanograms and stapedial reflexes. VAMP responses are myogenic potentials. They're not like ABR. So the responses are very big, bold, strong. The SCM is a big, strong muscle, and you will get very, very good responses. Here you will see, for example, the amplitude on the left is significantly decreased by at least 50%, but we have normal latencies. There are many, many studies that have established the gold standard in the norms for infants as young as 3 months of age to adolescents. The bottom line is they're almost identical to adults. What would you expect? Shorter latencies. Why shorter latencies? Shorter necks, right? So if you have a shorter neck, you're going to have a faster response. So they're easy to read, and we would strongly recommend any clinics that are concerned about evaluating pediatrics to include cervical VAMP. And actually, this is for any child where you want to evaluate vestibular function. We also like video head impulse testing. If you want the best sensitivity to see if you have unilateral vestibular dysfunction or a bilateral vestibular dysfunction, the video head impulse test is absolutely the very best. Now let me show you a little girl with vestibular migraine. She's about 5.5 years old. I'm going to put everything together for you. I'm going to show you the electrophysiology results for both the VHIT and the CVAMP. First of all, if you look at the result, children like this, it's very easy. What we're going to see, it's going to be abnormal with head impulses to the right, normal to the left, and we see her VAMP is normal. Now, what does this tell us? The CVAMP, the genesis of the CVAMP, is the sacral. It is also innervated by the inferior branch of the nerve. The VHIT, conversely, is looking at the horizontal VHIT that we did, looks at the horizontal canal and the superior branch of the nerve. So what we can see here is this child's vestibular migraine has affected somewhat the horizontal canal and the superior branch of the nerve on the right side, but has not affected the left side, and also neither sacral and neither inferior branches of the nerve have been affected. So it gives us a very complete look at the function of the entire peripheral system. And again, children tolerate the VHIT very, very nicely. We do this even on infants as young as 9-10 months of age. Well, I hope our short time together has given you some insight into vestibular migraine for pediatrics. I would like to invite you to visit the website. You have full open access to the Dr. Gans blogs. You can watch me work with dozens and dozens, perhaps as many as 50 video case studies with infants and adults. You also have complete free access to our many, many research articles and chapters, textbook chapters on pediatrics and on advanced diagnostics. I would like to thank Dr. Neha Shivastasa and her team and all the other wonderful presenters from India, Australia, the United States. It's our greatest pleasure and honor to be with you, and we look forward in 2023 to being with you live, perhaps in Mumbai and perhaps even Australia. So until we see you, my friends, we wish you the very, very best, and thank you for your attention. Hello, everyone, and
We extend our thanks to Dr. Richard Gans to take out time to share his presentation with us. Next, we have Dr. Joseph Sakumura from Team AIB Florida. Dr. Joseph Sakumura received the Doctor of Audiology degree from the University of Kansas Medical Center and his undergraduate from University of Kansas. He holds the Certificate of Clinical Competency from the American Speech Language Hearing Association and is board eligible from the American Board of Audiology. Dr. Sakumura's primary interests are in diagnosis and rehabilitation of balance disorders in a broad range of patients, children to adults, in addition to being clinical staff. We'll play the video now.
Hello and welcome. My name is Dr. Joseph Sakumura, and I'm the Chief Science Officer at the American Institute of Balance. We'd like to thank Dr. Neha and AIB India for inviting us to present today. The topic for today's discussion is vestibular migraine in adults, and we'll be exploring the impact that migraine can have on both the peripheral vestibular system and the central nervous system. Through our discussion today, we'll be exploring some pathophysiological concepts as well as treatment paradigms specifically when it pertains to dizziness, vertigo, and balance problems in patients with migraine. Thank you for attending, and we look forward to a very informative session. When looking at migraine, it's critically important to understand that this is so much bigger and so much more than just being a headache. It is a variable disorder of nervous system function, not simply a headache. And this is one of the things that causes so many issues with patients, and one of the reasons that this condition is so underreported and underdiagnosed is because historically, healthcare practitioners and patients alike have thought of migraines traditionally as being headaches. Thanks to our understanding of the pathophysiology, we now recognize, and the International Headache Society and the American Academy of Neurology, the gold standard governing bodies for this, understand and recognize that it is so much bigger than this. This is among the world's most disabling disorders. And again, as I mentioned previously, often affects individuals in their most productive years. We are starting to grow understanding of the pathophysiology of this, again, thanks in large part to scientific breakthroughs in genetic advances, animal models, and imaging studies. We now know that, again, this is a genetic neurological condition that affects, depending on the paper that you look at, somewhere between 12 and 17% of the general population. But understand that in a patient's eyes, right, if you bring up the word migraine and they've never had a headache, or they don't have a traditional clinical profile in their mind that exists with migraine, they're going to be a little bit resistant to the idea that this may be part of their problem or contributory to their functional impairment. So again, migraine has activation and neural substrates that exist almost everywhere within the brain and central nervous system. What we're going to spend the next couple of slides doing is looking at the clinical profile as well as pathophysiologic mechanisms within this condition, with the ultimate goal of understanding how they ultimately lead to these symptoms of dizziness, vertigo, imbalance, ataxic gait, etc. So this is not simply a vascular headache, as maybe it's been referred to historically in the literature. Again, ever since 2013, the International Headache Society has come out and said you can have a migraine without ever having a headache. So while if you look at the diagnostic criteria for vestibular migraine, a headache is mentioned within that criteria, you do not ever have to have had a headache to be a migrainer. That's a really, really important understanding that we as healthcare practitioners have, is that that is an old way of thinking of things. So again, may or may not have a headache, but regardless, even if there is a headache present, it's much bigger of a condition than just that. Let's now switch to this, change gears just a little bit from migraine as a global central nervous system condition and start to drill down a little bit into our understanding of migraine and the vestibular system. So it's really, really important to understand that there are two different things that we've got to consider when we're looking at a migraine patient that is presenting with dizziness. Number one, the patient can have an active, acute, or uncompensated peripheral vestibular dysfunction that can result in vertigo and dizziness. Right? So that's silo, or that's group number one, is patients that have peripheral vestibular dysfunction. The other category of patients we will deem vestibular migraine patients. These are the category that actually have intact peripheral function, but have changes somewhere in the central nervous system that are leading to the dizziness. So if we understand globally that any disruption or distortion of either the peripheral vestibular system or the central vestibular system, right, either of these conditions may result in dizziness, vertigo, or disequilibrium. The treatment modality, whether or not vestibular rehab will work, is completely dependent on our understanding of where the patient's functional impairment or symptoms are coming from. What is the locus? What's the etiology? So it's critically important to understand the difference between central dysfunction, right, migraine-related changes in the central nervous system that are causing these issues, or peripheral vestibulopathy, which is the cause, and then we can establish what the treatment plan looks like. Vestibular rehab will never cure migraine. And on top of that, vestibular rehab, with the exception of canalith repositioning and BPPV treatment, which we're going to talk extensively about in the next section, with the exception of canalith repositioning, vestibular rehab is never designed to prevent attacks of dizziness or vertigo. It's designed to facilitate compensation, thereby managing and helping the patient to feel better from previous attacks of vertigo or dizziness. So an example of a peripheral vestibulopathy would be things like vestibular neuritis, labyrinthitis, right? Meniere's disease, a nerve lesion, an ischemic attack, right? So really, really important that we understand first and foremost, where are these symptoms coming from? Is this originating from the peripheral vestibular system, or is this a central nervous system related symptom, which can happen as a result of migraine? So we have to understand that either of these can cause the problem. The good news is, if you've taken our course or others or have been treating these patients, we understand during our bedside evaluation quite quickly how to differentiate between the two, right? With peripheral vestibulopathy, we understand that this is going to likely produce a direction-fixed nystagmus that enhances post-head shake and causes impairment or challenges with the modified CAT-SIB test and the GANS SOP test. We understand that this will cause oscillopsia and all these other kind of things that are clinical findings of peripheral. So by quickly and efficiently ruling in or ruling out the periphery as part of the problem, we can then start to develop what an effective treatment plan is going to look like. The challenge that many physicians and therapists alike have is that we're treating these patients as if all of them are just dizzy. And they're getting referred, sometimes inappropriately, for physical therapy. You're going to see that PT, vestibular rehab, for patients with migraine with no peripheral vestibular abnormalities has limited, if any, improvement or efficacy. So the treatment has to match the diagnosis, the functional diagnosis. So we've got to understand this role between the periphery and the central nervous system, which is involved, and sometimes both can be involved. You'll see that we can have patients that develop peripheral vestibulopathy and have migraine. If peripheral vestibular dysfunction is present, they are a good candidate for vestibular rehab. However, if the dizziness is migraine related and the peripheral vestibular system is intact, therapy is going to be of limited benefit. So we've got to understand the different players in the game here: brain, ear, or both. So we've established that, again, migraine itself can cause dizziness, and that peripheral vestibular dysfunction itself can cause dizziness. Now let's dive down one more layer deep. To complicate this, we know that, again, migraine in the central nervous system can cause dizziness. We've established that. But what we also see with patients with migraine is a high prevalence of vestibular dysfunction, peripheral vestibular dysfunction, in patients with a diagnosis of migraine. So conditions like vestibular neuritis, Meniere's disease, labyrinthitis, ischemia, right? These happen at a higher rate in patients with migraine than those without. We also know that BPPV occurs 3 times more often than in a non-migraine population. So migraine may cause permanent vestibulopathy. There is a relationship here that is continuing to be investigated in the literature. Why this relationship? Why is peripheral vestibular dysfunction so much more common in patients with migraine, right? So step one, we've got to understand some of the overlap. So remember, we were talking a little bit about neuropeptides and neurotransmitters of substance P, neurokinin A, calcitonin gene-related peptide or CGRP, serotonin, epinephrine, these different neural components that are involved with the migraine pathophysiologic process. Guess where these transmitters are also found? The peripheral vestibular system. So, we have to understand that in patients with migraine, they are much more likely to have peripheral vestibular dysfunction. So we've got to determine if the problem, again, is vestibular, if it's migraine, or if it's both. Very often there is an overlap there. So remember, migraine itself can mimic peripheral vestibular dysfunction, Meniere's disease, etc. It can even mimic this in the sense of causing hearing loss. Not as common, but keep that in mind that the central nervous system, the migraine etiology, can cause all of this. So we've got to determine if the vestibular dysfunction is part of the problem or if this is simply a migraine variant. The gross term for this, for patients with migraine but intact peripheral vestibular dysfunction, is what we call vestibular migraine. Right? Vestibular migraine we would use to describe somebody that has dizziness that's coming from the migraine. And again, that migraine could be influencing the central vestibular nuclei, the vestibulocerebellum. So vestibular migraine, we use that term to describe just that type of population. If there is peripheral vestibular dysfunction, we could use terms like migraine-related vestibulopathy or migraine with peripheral vestibular dysfunction. So vestibular migraine is kind of the overarching, all-encompassing term, but the best way to describe migraine when there's a peripheral issue is, again, vestibulopathy, migraine-related vestibulopathy is what you'll see the literature describe this as. So we have to understand and recognize which is contributory to the problem, because they can look quite a bit like one another. So the first and most important step is to determine where the patient's issue is coming from. Often, hearing loss is a nice way to differentiate migraine from things like Meniere's disease because it's not as common in patients with migraine. So if you have a patient that's coming in with these Meniere's-like symptoms and they haven't had a hearing test or serial hearing tests or audiograms, this is a really good place to start with these patients. But understand that the brain can mimic, migraine can mimic almost anything. So we've got to recognize this overlap between the two. Now, if a patient has vestibular dysfunction and has migraine, they are great candidates for vestibular rehab. But if the migraine is causing, right, unstable fluctuations and dizziness that are related to these, right, serial attacks, vestibular rehab is never going to fix that, treat that, solve that problem. So again, vestibular rehab is designed to be implemented after a unilateral attack of vertigo, for example, or dizziness, to help address complaints of oscillopsia, dizziness, surface preference, visual preference. VRT is not going to fix migraine. So that's really important to understand. So here we have the both from the Barony Society as well as the International Headache Society. We have their definition of their diagnostic criteria here. So you can see almost very, very similar, if not almost exactly the same. We see that basically, right? Vestibular migraine has now become developed its own diagnostic criteria. Previously, we've described this as, again, basilar migraine or migraine with brainstem aura. We've now, with the recent updates, we have our own diagnostic criteria for this. So at least 5 episodes with vestibular symptoms of moderate or severe intensity. Again, looking for minutes to hours. Current or previous history of migraine with or without aura. 1 or more migraine features with at least 50% of the vestibular episodes. So you notice that headache is one of these, but it does not have to have a headache to meet this criteria. Right? The other big one that you see for definite vestibular migraine is not better accounted for by another vestibular or ICHD diagnosis, meaning that if someone has a vestibular neuritis, a diagnosed neuritis, or BPPV, or Meniere's disease, or labyrinthitis, or whatever it is, they don't meet this criteria for vestibular migraine. So again, vestibular migraine is used to describe patients that do not have a diagnosis of a vestibulopathy or a vestibulopathic disorder. So these are the criteria. Again, we have one for probable and a lot of crossover between these two organizations, right? The International Headache Society, the AAN, as well as the Barony Society. So understanding here, the big important one is not better accounted for by another disease or disorder. So we've got to be able, and if we're going to call something vestibular migraine, we've got to be able to, with our bedside eval, right, or neurodiagnostic eval, if any of you doing caloric, rotary chair, etc., VNG, we've got to be able to rule out peripheral vestibular involvement in order to come to the conclusion, or let the physician come to the conclusion, that this is in fact a vestibular migraine case. So we've talked about migraine as a central nervous system condition that in and of itself can cause dizziness. We also know that migraineurs carry with them a higher prevalence of developing inner ear vestibular conditions. So vestibular rehab in patients with migraine, when warranted, can be an absolutely tremendously effective treatment modality. But it has to be utilized properly. So the challenges that arise when a patient does in fact have vestibulopathy and VRT is warranted, if that patient has migraine, VRT can be effective. However, you've got to consider a couple of things. Number one, migraine is typically a non-stabilized condition. So when we talk about, in our basic course, in our first course, our foundational course, when we talk about the ideal vestibular rehab candidate, right, we talk about that person being stabilized but non-compensated. The term stabilized simply means that the patient is not having recurrent attacks of vertigo. They've had an attack of vertigo, but they are now stabilized and dealing with the residual symptomatology that resulted from that attack of vertigo, things like oscillopsia, balance problems, surface or vision preference, etc., etc. Now remember, we're not talking about BPPV here. That's in the next section. So these are patients with uncompensated vestibular dysfunction, typically unilateral. So the fact that migraine makes these people unstabilized is going to be a challenge. Hormonally linked and highly volatile can make this challenging. Migraineurs having a predisposition for motion intolerance can make this challenging, as well as other co-occurring or comorbid conditions like migraine anxiety-related dizziness, depression, anxiety, cervical problems, diabetes, hypertension, all these other kind of things that we know can often accompany a diagnosis of migraine or occur with migraine. So yes, the answer is you can use vestibular rehab therapy with migraine. VRT can be effective with migraine, but the story is you've got to ensure that even when you're going to employ VRT and use gaze stabilization, adaptation, substitution, habituation, when you're going to use this intervention strategy, you had better make sure that the patient is also receiving treatment to stabilize the central nervous system condition of migraine. So whether it's medically managed, whether they're addressing hormones, whether they're addressing stress or sleep hygiene, or whatever else has been linked to being involved here, it has to again be a lifestyle compliant modification, lifestyle treatment paradigm. It can't just be the VRT. The vestibular rehab is going to help address residual impairments of oscillopsia, balance problems, and these kind of things. However, it must also be paired with treatment for globally the migraine that exists, this type of genetic makeup that this person is. So keeping in mind that yes, vestibular rehab treatment, vestibular rehab as treatment for vestibular dysfunction in patients with migraine is effective. However, the VRT, the vestibular rehab therapy, is not going to fix the migraine. It's not going to stop headaches, dizziness, or these kind of things that are coming from the central nervous system. So VRT is not a treatment for migraine. VRT is a treatment for associated symptoms that may have developed from the peripheral vestibular system, which are highly associated with patients with migraine. So you've got to always think to yourself, treating function, function, function. If they don't have functional impairments of oscillopsia, dizziness, imbalance in between these episodes that may be migraine associated, VRT may not be a viable management strategy. They have to have a clinical profile that supports using this. If they do, the literature is very clear that it works wonderfully. That's what I'm going to share with you in just a minute here. When you're considering VRT with migraine and implementing this treatment modality or strategy, a couple of things we've got to keep in mind. Number one, is the patient compensated or non-compensated? Thinking back to basic vestibular rehab and basic vestibular anatomy, right? We've got to know if they're exhibiting the signs and symptoms of a non-compensated VOR or VSR. So looking for things like oscillopsia, looking for things like balance dysfunction, looking for things like head movement provoked dizziness. So understanding their makeup, are they compensated or non-compensated? Remembering the cardinal signs and symptoms of a non-compensated VOR or VSR problem. Understanding what is their current complaint and functional impairment. Are they suffering from recurrent episodes of vertigo and dizziness? In between these episodes of vertigo or dizziness, are there residual or lasting symptoms? Again, I will repeat, if the problem is recurrent episodes of migraine-related vertigo, and there are no residual balance impairment or VOR dysfunction, VRT may not be a viable approach. So understanding what their current functional impairment is and targeting therapy at that functional impairment. Every patient is an N of 1. You can't do cookie cutter rehab. If they are non-compensated, in what frequency region of head movement are they non-compensated? Using a functional diagnosis-based strategy to target therapy to their specific impairment. Not every patient is going to have a problem with slow head movement. Some people will only be non-compensated in the mid to high frequency regions. So the rehab has to match their functional impairment. Are the migraines medically managed? Are they stable? Right? If not, we'd better also focus on getting the patient pointed in the right directions in terms of managing the migraine, whether that's medically, whether that's trigger identification and removal, whether that's lifestyle modifications, hormone replacement, any of these different kind of things, we've got to make sure that we're also addressing the underlying condition. Treating the non-compensated peripheral vestibular loss is great. However, if the medical condition that's leading to that problem is not managed and taken into consideration, the patient may end up right back in VRT a couple of months later. So we've got to make sure that we're addressing the underlying origin or etiology. Again, is this a migraine-related vestibulopathy? Is there a true peripheral vestibular dysfunction, hypofunction, or vestibulopathy? Or is this vestibular migraine? Is this migraine with vertigo as an aura? Is the patient having dizziness that is technically central in origin? The treatment has to match this. Remember, I'm going to show you some of Herdman and Whitney and Furman's papers that demonstrate the utility of vestibular rehab, but this is with the agreement that the patient does have vestibulopathy. VRT, again, I'm kind of like a broken record here, will not treat or fix the migraine itself. So what are the signs and symptoms of an impaired VOR or VSR? Again, looking at the special test battery that we teach in our foundations class, the GAN Sensory Organization of Performance Test. So the Fukuda, the Romberg, the CATSIB, the Clinical Test of Sensory Integration of Balance, right? Is there any spontaneous or gaze-evoked nystagmus? If there is, does it suppress with vision? Is it direction fixed? Is it direction changing? Is the head impulse or head thrust test positive? If so, to which side? Is it bilateral? Dynamic visual acuity test, the clinical test for oscillopsia. Again, we're not going to take a deep dive into each of these tests because we're going forward under the assumption that we're all at least familiar with the special vestibular test battery. But simply put, is there a peripheral weakness at play here, or are all of these tests normal? Again, in patients where the GANS SOP is normal and there's no spontaneous or gaze-evoked nystagmus, no positionally provoked nystagmus, the head impulse test is normal, dynamic visual acuity test is normal, right? These patients are not going to be good candidates for vestibular rehab. So understanding what's contributory and then executing treatment as necessary based on that information. So here are a couple of the sort of gold standard, if you will, papers and publications, high impact literature that explores this idea of vestibular rehab in patients with migraine. So the one on the left here basically looked at physical therapy for migraine-related vestibulopathy and vestibular dysfunction with history of migraine. So again, establishing that these patients have a peripheral vestibulopathy, right? How do they do with therapy? And what they find is that the answer is yes, therapy works. In terms of their outcomes, we're looking at balance function, so physical performance improved, as well as self-perception of abilities and subjective report of improvement from these patients. So absolutely, patients with history of migraine that develop vestibular dysfunction are great candidates for vestibular rehab. The other paper over here looks at, again, vestibular rehab outcomes in patients with history of migraine, and they found very, very similar. So what they found was that basically they demonstrated improvements in both subjective, right, as well as objective and clinometric findings after VRT. So understanding that, again, each patient is an N of 1, the treatment intervention, the actual vestibular rehab exercises that you're doing have to match the profile of the patient for improvement. But here's the literature supporting that the use of VRT in patients with migraine and with vestibulopathy is extremely beneficial and is absolutely a viable treatment option. These are also really nice physician marketing pieces. if you're marketing your services or yourself to physicians that see a lot of migraine, these are really, really wonderful papers to sort of break the ice with those docs in terms of why their patients could benefit from your services. Thank you all very much for your attendance during today's discussion on vestibular migraine in adults. We hope that this has been informative and that you've learned something new, and we encourage you with any questions to visit aibindia.com.
We extend our thanks to Team AIB Florida, Dr. Gans, Dr. Sakumura, for taking out crucial time for sharing their presentation with us. They will be visiting us in Mumbai for a live session in 2023. It gives me immense pleasure to invite our director, Dr. Neha Srivastav, for the next presentation. She is the youngest member of Barony Society and is also a member of American Headache Society. She is practicing consultant, neurootologist, and ENT specialist of RTKL, Vertigo, and ENT clinic in Mumbai. Masters in MS ENT from Padma Shri Dr. D.Y. Patil Medical College and Hospital, MBBS from Tarna Medical College and Hospital, Mumbai, co-owner of RTKL Diagnostic Mumbai, author of many research papers and publications, has been an integral part of workshops and conferences globally. Dr. Neha.
Good evening, everyone, and it gives me an immense pleasure to organize the Trination Webinar today. We had a lot of stalwarts representing from Australia, and it was a pleasure to have Dr. Gans and Dr. Sakumura. We at India, we believe in, AIB India believes in cost-effective treatments, low-cost treatments for vertigo, and we believe in health for all. So basically today my topic is pharmacotherapy in vertigo. This is most commonly practiced, and I'm very sure those who are listening to me all over India and various parts of the world, they are well versed about the drugs. But there are some ifs and buts also. So as we go on through the slides, we will also talk about the prevalence rate and the epidemiology and the different variants of vertigo that we see and the major medicines that we come into use. Of course, as I was going through in the last 2.5 hours, there were a number of questions being asked with regard to medicines, which we'll be, of course, discussing in our panel. So let us go through this slides. So coming to the epidemiology, as we all know, vertigo is a subjective symptom of balance disorder. So it is more about the patients and not about us. We have to understand from their perspective. The lifetime prevalence rate in adults is about 7.4%. Of course, the female populations are affected more, and 3 times more are the affected are the elderly population. Also, in one of the research papers, it was conveyed that every individual once in their lifespan gets a dizziness. So that is one more thing that we can think about. But there are a number of reasons for same. Let us move on to the next slide. Challenges that we face in treating a condition. Now, by the time patients come to me in my particular clinic, they are already very debilitated, and the condition is so worse that they are not even in a position to have a treatment or maybe go under evaluations for their tests. And secondly, they have a loss of morale, they have lost self-confidence, there is emotional and psychological setback. They are not able to explain their problems even to their family members. They don't have anyone as their, the Razdar, whom we call that, who can take care of them, or maybe they can explain the situation because they're such in a position. There are multiple specialty or doctors that they visit. They visit their physicians, then they visit their orthopedic. Orthopedic suggests to go to neurologist. By the time they come to an ENT, ENT is not in a situation to understand that what variant of vertigo is he undergoing. As I mentioned, high cost of diagnosis, because right from doing an audiogram impedance, which is of course much cheaper as compared to MRI of the brain, and of course the vestibular evaluations that has come up, it is a financial problem since it's not been covered under insurance as of now. And it is also an underdiagnosed condition. So basically, when we talk about vertigo, we just see the tip of the iceberg. We never see what's gone below the sea level. So we have to understand as to where is the root cause. And when we go deeper down, we dig into the case, we come to the conclusions. So it's quite easy. But the only thing that a clinician has to understand that you have to give time to your patients. In case if you don't wish to give it, then it becomes quite tough for you also to understand, and the patient will go on referring to other specialties too. Coming to vertigo, as I mentioned, it is a wide spectrum of disease, of course, because it starts becoming like, I always label it as 6 classifications that I always go through. So first I will talk about the central case, which is more related to the brain, spine, and the foot. The peripheral, which is the eyes and the ears. Systemic illness. See, not all vertigos come from the peripheral. Some are related to dehydration, maybe hypertension, sugars. These all things have to be taken into accountability. Psychogenic form, underlying anxiety, depression, they also become a part of the process. As mentioned by Dr. Sakumura in the last slide about vestibular migraine, where he has spoken about migraine, anxiety-related dizziness, autoimmune conditions, lot of relapsing polychondritis, SLE. They all also was one of the standout cases when you have autoimmune ear diseases, drug-induced conditions. Long-standing cases of taking vestibular sedatives can lead to vestibulopathies. We need to understand as to how much we have to give and how much time. So basically today my slides will focus on that. Of course, when the patients have a long-standing cases of taking maybe an alpha adrenergic agonist and of course beta blockers or long-standing diuretics, and anticonvulsants like phenytoin, they also get drug-induced ataxia. So these things also have to be kept into mind. Management. So the management is reassurance. Please confide with your patients. Let them build trust in you. Their trust and your suggestions can help them to get out of it. Canale 3 positioning maneuver. Yes, there are specifically for BPPV. So there are 14 variants of positional vertigo, and there are 12 maneuvers to treat them. So we need to understand, go into the depth of understand, because not everything is Dixalpike and Epley's maneuver. There are a lot more than that. And Cowthorne, Cooksey exercises and Brand-Dorff don't always work. In fact, you may stimulate those canals and further worsen the case of that patient. Vestibular rehabilitation therapy, people bring on giving chits, giving the papers, do this exercise, that exercise. No, there is a fixed regimen which has to be followed. You start from the VORs, go to the VCR, and then to a VSR. What I mean to say is, when we treat the vestibular ocular reflex, in a position treat to vestibular colic reflex, which is in the neck, and then you go up to stabilize the spinal reflex. So there is a fixed regimen which has to be followed, and this is the point where AIB India enters to rehab the cases. Pharmacotherapy, of course, plays major role in migraines and adjuvant therapies, and also for the abortive methods as I go ahead. And surgery are rare. It's only when the things go out of hands that you have to think about surgery. Coming to pharmacotherapy, now it's now, as the slide looks, it's quite a good slide with the bottle and the medicines wobbling around. So basically, it's for the abortive treatment. So the first thing, the main reason that we take medicines is to reduce the sense of motion, enhance the vestibular compensation, reduce the neurovegetative symptoms like anxiety, nausea, vomiting, headache, reduce the risk of falls and fractures. We don't want a head injury to happen or a hip fracture, which we commonly see in post-vertigo cases. And of course, we want to improve the quality of the life of the patient and make it easy for them. So as I break down those medicines, it's the vestibular drugs. So one is a sedative, the other class is a stimulant, and the third is a neuroprotective actions. Coming to sedatives, we'll talk about antihistamines, calcium channel blockers, benzodiazepines, and antiemetics. Coming to stimulant, we have only one, that is histamine agonist, and third is an neuroprotective agent, which are nootropic agents. These are quite commonly used by my friends in neurology. So we'll go ahead in that. Yeah. So talking about antihistamines, so vestibular sedative. Well, meclizine is an FDA-approved drug, quite less used. And there were questions coming up. What is used in the first trimester in pregnancy? Well, meclizine can be used in pregnancy. There are disease studies which suggest that it can be used, can be given. But it is, let's see, every clinical trial has a resistant number of cases. So we have to understand the situation of the patient. They can also be managed by an PPI and ondansetron. So see how the symptoms are. It is basically an H1 receptor antagonist. Dopamine antagonist works on D1, D2 receptors, has an anticholinergic effect like dry mouth, dilated pupils, and increased heartbeat. It is a very good drug to prevent motion sickness, can be given 1 hour before the travel and reduce the severity of the symptoms. It is a class of sedatives, so of mandatory it becomes a CNS depressant, and thus it works on inhibiting the vestibular compensatory mechanism. So if you're thinking of applying a vestibular rehabilitation therapy with meclizine, sorry, it will never happen. Going ahead, as we talk about calcium channel blockers, these are the next available OTCs, quite favorite of a lot of GPs as I go through their prescription, that is Sugeron, that they most prescribe. Well, it is a selective antagonist which works on the T-type voltage-gated channels. It is having an anticholinergic, antiserotonergic, and antidopaminergic effect. So basically, if you go to see, the migraine cycles work on all the three neurotransmitters. So it is also one of the class of drugs which works really well even the patient has a vestibular migraine. So it can be a choice if you want to abort the attacks between the first 3 days. So you can use among that. It inhibits the flow of calcium in the endolymph into the cells of crista ampullaris, enhances the microcirculation in the inner ear and brain. But the major side effects that you will have is an extrapyramidal symptoms. I have seen cases, patients presenting with severe ataxia, taking the combination 25 milligram thrice a day, twice a day, presenting my OPD. The first thing that I do is to stop the medicine and then evaluate the patient. So I get the resting phase of the patient as to how the patient is performing. The other things are weight gain and depression, considering that it has an antiserotonergic effect. The third is benzodiazepines. See, benzodiazepines were always considered to be a very good for anxiety medicine, but it has other two properties like anticonvulsants and muscle relaxant. We very well know that it is having a high safety margin. So, of course, the dose can be stepped up. But how much? The question is how much you want to give, until when? So basically, it binds to the GABA BZT receptor chloride channel complex, potentiate the inhibit effect of GABA. It is a centrally acting, again, it's a CNS depression. As I mentioned, it is an anti-anxiety, anti-convulsant, and muscle relaxant. High safety margin, as I have told you, and there is effective in short-term usage. But in long-term usage, especially post 50, 55, it has a cognition deficit. So if you want to have a rehabilitation mechanism with the patient, you cannot have them on sedatives for a very long time. The moment they will have a cognition deficit, they will they'll not be in a position to even answer 1 + 1 = 2. The cognition means they are able to reason out as to what they are doing. They are in which environment right now. What is the place, time where they are sitting right now. So the cognition effects have to be in one of the very good state when we are dealing with a rehab in a patient. So this has to be kept in mind. The other things are addiction. Considering that alprazolam process, the blood-brain barrier has a strong addictive action, and then withdrawing the medicines becomes a huge task. Sedation is always there with this particular class of medicine. Coming to antiemetics, we all know the potency of prochlorperazine, highly potent sedative, one of the good choices of medicines when it comes to vestibular neuritis, but it blocks the dopamine receptors, has an antipsychotic and antiemetic effect. Always use it for short course to relieve symptoms. You can use it for 3 days, no problem. Go ahead and use it, but don't give it more than 5 to 7 days. You are starting to induce pseudo-Parkinsonism in the patient. You're going to see extrapyramidal symptoms. You will have patients coming with breast pain because of the rise in the prolactin levels. We don't want the patients to have pituitary adenoma, pituitary microadenoma, coming to the gynec lab and going and taking cabergoline to just reduce the prolactin levels. So just keep this in mind. Hypotension is another leading cause of prochlorperazine, and of course the anticholinergic effects. Coming to histamine agonist, I am a very good favorism in beta histine, with quite less side effect as compared to the other medicines that you see. Basically, beta histine is an H3 inverse agonist. So basically, what you mean by that word is when the beta histine goes, it blocks the receptors in the like a agonist, but it gives a spontaneous action of antagonistic also, and it works on all the 4 systems. So this is an H3 inverse agonist with a weak antagonistic aspect of H1 receptor. It is a non-sedating drug. So one thing is taken care by this, that the cognition deficits are not going to be impaired. We use it in elderly populations also. There is a good vestibular compensation in this case, and headache and dyspepsia. That's the only 2 side effects that we see in these cases. So you can always think of adding maybe a PPI along with that. The only contraindication is a pheochromocytoma, because pheochromocytoma is an adrenaline releasing tumor. So basically, when this beta histine acts on it, it is also acting on the epinephrine. So that is why this is contraindicated in pheochromocytoma. Coming to the nootropic agents, quite well used among my neurologist friends. They use it even to improve the cognition of the patient. Piracetam, zinchkobilo was quite often used even in cases of tinnitus among the ENT fraternity. So basically, that is their concept, that is reduce the vertigo attacks after a head injury or a vertigo of a central origin. It is having a role in vertebrovascular sufficiency. Some say that it also improves the circulation by thinning of the blood, just like an aspirin. And increases the microcirculation, has antioxidant properties, and it works really very well in improving the cognition of the patient. So when you're dealing with a case of +60 or +55, you can always keep this medicine by your side. They will help you in treating the case. So basically, my final take-home message is that every case is different. You do not have a standard protocol in treating a vertigo case. It will have to be made by the clinician, keeping in mind all the history taking, the clinical examination, the neurootological examination, the vestibular evaluation, or in worst cases, even the imaging. I had mentioned in my last program also in MentCon that more the symmetry, the more the higher chances of it being a peripheral vertigo. The more the asymmetry, the more is the higher chance of it being a central vertigo. Central versus peripheral vertigo is quite a long topic, but just keep in mind that 3Ds are the red flags: diplopia, dysarthria, dysphagia. These are the red flags. Canaletheric positioning maneuvers are the only treatment for positional vertigo. You can always add a beta histone when you're treating the case just to avoid a residual giddiness. Vestibular rehabilitation therapy is the end result or the end treatment for any peripheral vertigo cases. And medicines, especially when it comes to migraine, the medicines like flunarizine, propranolol, and amitriptyline, which are the first line treatments for migraine. And apart from that, you can always add the vertigo medicines based on the choices, based on the case, to abort those attacks. And thank you. And we will be taking up the questions in the panel discussion.
Thank you, Dr. Neha, for organizing this program and also for this comprehensive presentation. It is always a pleasure to hear from you.
Okay, so our next event is a panel discussion. We have a fantastic panel of speakers with us who will discuss all about vertigo and discuss the questions that have been mentioned by you before the event. And we'll try to cover some questions that you put us live in the chat box that you have an option below. The panel will be moderated by Dr. Shilpi Saxena and me. Our panelists are Dr. Neha Srivastav, and I will now let Shilpi ma'am introduce the other three panelists, Dr. Dinesh Singh, Dr. Kavita Sudarshan, Dr. Vijay Kadam, and we also have Dr. Vikram Khanna here with us who will join us on the panel.
Thank you, Kansha. So please have a seat, Dr. Neha. So Dr. Kavita Sudarshan is an MS ENT, gold medalist. She has been practicing neuro-otology for over a decade now. After completing her training under the best minds in our country, she has her own vertigo clinic in Mulund, which is well equipped with VNG. She also consults at Shruti Hospital, Apollo Spectra, and Sushruti Hospital. She has various publications in national and international journals. Dr. Dinesh has completed his MD Internal Medicine with a gold medal and has also earned a DM Neurology degree, during which he has also topped the university. Recently, he was recognized and awarded as one of the most promising and inspiring neurologists in India by the Economic Times. He also won the Golden Aim Award for Most Preferred Neurologist in Mumbai. He currently practices in Neuron Clinic, Borivali, and Mira Road in Mumbai, and is attached to outstanding facilities like Bhakti Vedanta Hospital and Karuna Hospital in Mumbai.
I would also like to call upon Dr. Vijay Kadam. So can you please join us on stage? He's a medical advisor and medical affairs for Sun Pharma. He's in public health expert, UG from Grand Medical College, Mumbai, and a PG in preventive and social medicine from St. JS Medical College, Mumbai. He worked with MSD, Merck Sharp, and Dome, where he rolled out the antimicrobial stewardship AMS program across India and promoted rational use of antibiotics. He worked with Janssen Pharmaceutical Division of Johnson & Johnson, where he launched the beta-quilline drug for treatment of MDR, XDR tuberculosis. We also have Dr. Vikram Khanna, who's an MSENT DNB. He completed his MSENT in 2002 from Sion Hospital, Mumbai, under Professor Renuka Brado. He is in private practice ever since 2004 in Mumbai. He has special interest in the field of allergy, vertigo, and endoscopic ear surgery. He has given talks and participated as a panelist in various conferences. Dr. Dinesh is yet to join us due to some time lag, but we'll take the questions for the other panelists now. Can you add Dr. Kavita on the screen as well? Yeah. Just press it, long press, and it'll start working. Hi, Dr. Kavita, can you hear us?
Yes, yes.
Thank you so much for joining us. Dr. Dinesh is just joining us. He has one last OPD where he'll be joining us shortly. Okay.
So, Dr. Kavita, first question for you. Dr. Anju from Bangalore wants to know about effectiveness of Epley's maneuver in BPPV.
So I believe that Epley's is extremely effective in all cases of posterior canal vertigo. However, if you have an obese patient, or if in patients where the Epley's has not been very successful, like after doing it maybe once or twice, and you've ruled out multi-canal disorders and migraines in such patients, then you can move on to Simmons, and also you have the Gans maneuver for the same. I think Dr. Neha can explain the Gans maneuver much better.
Kavita, I will have to have a bed here then to have a maneuver happening. But the only thing is that you can skip the cervical spine when you're doing the maneuver.
Correct.
And the maneuver becomes quite easy. And it's a brisk maneuver. So have to be a bit quick. If we get time, of course, the audience who are present here will have a good view. Or else we will have to arrange for a bed here then. But Gans repositioning, the only thing is that the spine, even if it is compromised, you can go for it. That's the only thing I can tell you.
What is also important is the pre-maneuver and the post-maneuver preparation and instructions to the patient. Patient must be clearly told that one sitting of the maneuver may not be enough and we may have to do it a second or third time. Also, the importance of post-maneuver rehabilitation exercise must be explained and counseled for. Sometimes our patients carry the impression that once you do a maneuver, that's the be-all, end-of all of it, that we should counsel our patients and forewarn them that the patient may require certain, a couple of other sessions with us, and so that they don't harbor any false expectations, especially in private practice.
Right, I agree.
So thank you, doctors. Dr. Neha, the next question for you. Dr. Maya from Bangalore has asked for what are the food triggers for migraine? Pharmacologic remedies for migraine?
Okay, so pharmacologic remedies are medicines, as I spoke in my lecture, that it can be like there are only 6 medicines available, that is amitriptyline, flunarizine, propranolol, desvenlafaxine, topiramate, and divalproex sodium. Apart from that, the non-pharmacology includes caffeines, chocolates, popcorns, pickles, low salt diet, fermented foods, alcohol, having a proper disciplined lifestyle, reduce screen time, because that's the major thing that's happening right nowadays. So these are the key things which are non-pharmacological elements that has to be taken care of migraine. I would also add one more thing, that there are blue tint glasses which can be used by the patients, which are good at reflecting the light when you're using in front of the computer. And also you can use the principle of 20-20-20, wherein you can have, if you're in the screen time for 20 minutes, just come out of that, go for a long distance watch, or maybe having a green view behind, that can help you to reduce the pressure over the eyes.
Okay. So Dr. Vijay, Dr. Sutikshan from Amritsar has inquired, is cinnarizine, diphenhydramine combination better than beta-histamine in true vertigo? What are the absolute indications of beta-histine, cinnarizine, diphenhydramine?
Great. Thanks for that question. So I'll take that beta-histine. So beta-histine is indicated in vertigo, loss of hearing sense, and the tinnitus, which is basically associated with Meniere's disease. So it is indicated in that condition. And as you have seen during Dr. Neha's presentation, cinnarizine has the EPS and the adverse events. So the FDC, generally what we have seen in the practice is that the FDC is for a short duration they start, and then they switch over to the Betavert or the beta-histine molecule for the long treatment. Thanks.
Dr. Neha, there's Dr. Said who is live with us here.
Okay.
What's the maximum dosage of beta-histine that we can give?
But what is the case that he wants?
If you all want to ask in person.
Suppose if I make a scenario, if it is a BPPV, if it is a case of residual giddiness, see, that's my formulation that I use it. Basically, it's 8 milligram thrice a day for 2 days, twice a day for 2 days, and once a day for 1 day. And I taper it off. Call the patient after 1 week after the medication and the half-life and the excretion has happened from the kidney, and call back and review after 8 or 10 days to check for the maneuver. but there are different things associated with some people want to check it immediately after they have done the maneuver, some call after 3 days. This is what I follow, the guidelines. Of course, these guidelines are not from even AIB Florida, but this is what I follow when it comes to a case of BPPV. Second, when it comes to Meniere's disease, I would go up to beta histine 24 milligram OD once a day. But as Dr. Mariam also mentioned, going beyond 48 milligram is not what is not it's suggestible. But even it's my personal choice that going beyond, I would not go beyond 48 milligram if I want to treat the case. And even if I'm giving 48, I'll taper it down in 10 days time in an acute attack of Meniere's.
Thank you. Next question is for Dr. Dinesh. Dr. Dinesh, thank you for joining us. Our question is for you. Dr. Sanjay Betia wants to know about treatment of vertigo in the first trimester of pregnancy. Dr. Dinesh, am I audible to you? I think you're on mute.
Yeah, I can hear you. Yeah.
Yes, you can go ahead. Yes, we can hear you. Go ahead.
Yeah, tell me what. I didn't get the question. Sorry, can you please repeat?
Yes, the question is, Dr. Sanjay wants to know about the treatment of vertigo in the first trimester of pregnancy.
Treatment for vertigo in the first trimester of pregnancy, if it is benign paroxysmal position vertigo, there are only maneuvers that are available. The only thing that probably can be used safely, if at all anything, would be prochlorperazine, that is Temetil. Other than that, it is better not to use anything other than the maneuvers.
Okay.
And the second thing, of course, you try to find the etiology and then treat that.
Okay. All right. Dr. Prateek wants to know about the role of flunarizine in vertigo as such. If you could speak.
Flunarizine in vertigo. Okay. Flunarizine in vertigo, what I personally use flunarizine in vertigo is people where we have a definite diagnosis of vestibular migraine, because being an antihistaminic drug, it works both ways. It's a good migraine prophylactic, and it might, theoretically, because we use a lot of meclizine and cinnarizine for, short courses in treatment of vertigo. So looking at it that way, you can use it, but it is only if you're diagnosing it as vestibular migraine. Per se, for vertigo, it is advisable not to use flunarizine unless you have a diagnosis of vestibular migraine. And that too, you have to use it with a lot of caution. Caution in the sense, you should avoid it in elderly, because I've seen a lot of people having significant extrapyramidal side effects with long-term flunarizine use. So if it is vestibular migraine and the vertigo is because of vestibular migraine, then it makes sense. Otherwise, purely vertigo, better to avoid flunarizine.
Okay, so doctor, if you could just add the dosage, how much we can give?
Flunarizine, the maximum dose is 10 milligram at night. You can start with 5 milligram depending on how the patient tolerates it. The side effect is drowsiness or somnolence. If the patient tolerates 5 milligram well, you can build it up to 10 milligram over a period of next 10 days and continue it as less period as possible. Once you get a good migraine control with 10 milligram, you can quickly jump down to 5 milligram. And it at most maybe 6 months, not more than that.
Okay, thank you, doctor. Question for you, Dr. Kavita. Dr. Shankar from Hyderabad has asked about treatment of BPPV.
Treatment of BPPV in my situation would solely be maneuvers. But of course, you must make sure, I think in BPPV, it's very important that the nystagmus coincides with the canal that you're testing. So if you're sure that the nystagmus is coinciding with the canal, then go ahead with maneuvers. That will completely work. You can, normally I call back the patients after 48 hours to recheck. And like Dr. Vikram mentioned, I also give them post-maneuver instructions. I ask them to lie down straight at an angle of 30 degrees for a period of 48 hours. Try not to turn to the provoked side. And that should help. Also, another thing that I have commonly seen is that patients of migraine also have BPPV. So that also should be ruled out.
Okay, next question is for Dr. Neha. Dr. Raju from Surat has asked the role of meclizine.
I just explained in my lecture about the same. It's an anti-histaminic effect of the meclizine that is being used, and it is an histamine antagonist and dopamine antagonist. So that is how it works, and it's quite effective in motion sickness. I've answered it in my slides.
Okay, thank you, doctor. So
I just like to add one point that since it inhibits the compensatory central compensatory mechanism, ideally it should not be used for more than 3 days.
Okay. So, Dr. Dinesh, what is the role of aspirin in vestibular migraine?
Role of aspirin in vestibular migraine. There is no role for aspirin in vestibular migraine. Is it aspirin really?
They must be talking about VBI.
They must be talking about VBI because we just received a small question live just now. So we just, yeah.
No, if you're clinically suspecting a vertebrobasilar ischemic event or a vertebrobasilar TIA, aspirin is the drug of choice. Usually what we follow is if you're very sure about a diagnosis of vertebrobasilar TIA, we use double antiplatelets for minimum 3 weeks and then switch the patient to a single antiplatelet, which you have to continue lifelong. And at the same time, you do a vessel imaging, that is an angiogram. And if it is amenable to any surgical procedure or any revascularization procedure, you should offer them that. But once you start aspirin, my way of going ahead with that is you continue it lifetime. And the second antiplatelet, you can take it off in about 3 weeks' time.
Asha, I would like to, there's one more question that we have getting, sir, that how often is a patient of VBI misdiagnosed as BPPV? I would like to have your inputs on this.
VBI being missed as BPPV. I don't think it's, I mean, it's very difficult to miss BPPV. You should not miss BPP. It's very, very difficult to miss, to misdiagnose TIA or a vertebrobasilar stroke. And BPP, what it happens, particularly when the patient comes to you when he is not having that event and you're not able to, pick up the nystagmus on your maneuver. So there is something which is called a central BPPV. So one way to suspect central BPPV is when you've done the maneuver and that maneuver has failed, or you're seeing an atypical nystagmus during the maneuver. But usually we look at VB vertebrobasilar TIAs in BPPV when our maneuver has failed. Maneuver has been done rightly and it has failed and the patient has no improvement despite the maneuvers. Then you should think of vertebrobasilar TIA, but it's very rare. BPPV is usually a clinical diagnosis. It should not be this.
So there is one more question I would like to. I know these are actually live questions which are coming, and I am very sure you will be answering it much better than us. Which medicine is effective in vestibular migraine, like amitriptyline, topiramate, and flunarizine? Sir, you please explore on the choice of the medicine and when do we choose this among the 6 that we have.
Whatever data we have, the data says that one medicine is not effective over the other. You have to use, basically you have 5 migraine prophylactic medications. One is your antidepressants, that is amitriptyline. These are all level A evidence. I'm not talking about the level B, level C. There are a lot of drugs which can be used. Level A is amitriptyline, divalproate, topiramate, flunarizine, and beta blockers. So these are the 5 drugs that you have in migraine. There is no 6th prophylaxis for migraine. And the same holds true for vestibular migraine as well. You have only 5 prophylactic medications. Now, your choice of prophylaxis should be based on the patient profile and not on the patient symptom. So if you have a lady who is having a lot of depression in the background, then you should avoid beta blockers and flunarizine. Okay. And preferably use amitriptyline, right? If you have an elderly patient who has vestibular migraine, you avoid amitriptyline, you avoid flunarizine, you avoid dival because severe extrapyramidal risks associated with these drugs. So your choice of medicine would be propranolol in that case. If you have a young who is with no other comorbidities, your drug of choice should be topiramate. And the drug that you should avoid is sibelium, that is fezin. You should avoid divalproate because both these things will increase the weight. And if you have a female or a male who is very lean and very thin with no other comorbidities, you can use flunarizine or divalproate because they help in weight gain. If you have a patient of vestibular migraine who is an asthmatic, never use beta blockers. You can use the rest of the medication. And any other patient profile, if you have a patient with epilepsy who has vestibular migraine, your drug of choice either will be valproate or topiramate. And what you should remember is in epileptics, avoid tricyclic antidepressants and calcium channel blockers, that is flunarizine, because they lower seizure threshold. They do not cause seizure, they are not pro-seizure, but they lower the seizure threshold. And lastly, any patient with glaucoma, never ever use topiramate, because topiramate is absolutely contraindicated in glaucoma. And if you know that a patient has glaucoma in the background, never use amitriptyline, because amitriptyline also increases the intraocular pressure. Yeah. And if your patient is on amitriptyline and he goes to an opthal for a routine eye check and you find that he's got high pressures and the opthal has said that they have glaucoma, immediately stop the amitriptyline. So in cases of glaucoma, you can use divalproate, you can use beta blockers. Beta blockers work both ways. They'll help in glaucoma. So you can use flunarizine in that case. So these are a few scenarios. You have to be very smart in choosing a medicine as per the patient profile. There is no clearly indicated drug that this is good for vestibular migraine, this is good for hemiplegic migraine, this is good for classical migraine, this is good for migraine with aura. It basically depends on the patient profile.
Thank you, Doctor. Question for Dr. Kavita. Dr. Praveen from Coimbatore has requested approach to giddiness.
Approach to giddiness is everything. No? You start with a detailed history taking in such cases. Let the patient explain what the symptoms are. Let them start from when it really first occurred. Even though their histories are sometimes very long and they get lost and intertwined in it, let them speak. I think that is very important because it helps you pick up a lot of cues. Let them come back to, when was the last episode of giddiness, the duration, and there's just so much in the history itself. And after the history, of course, something very important is never forget the basics, like, the basic pulse, BP, having your entire complete blood count profile, having a thyroid profile, an ECG wherever necessary. These things are also important. And then you come down to your clinical examination. And always, always, always do the entire battery of clinical examination. Even if you're just suspecting, like, say, positional vertigo, and you just directly jump in for the Dix-Hall pipe, never do that. Do the entire battery, do the rompers, your tandem, your high stepping gait, all your oculomotor reflexes, your saccade, smooth pursuit, everything can be done clinically. Even so much so that you can even check for spontaneous nystagmus, when the patient comes, even if you don't have a Frenzel glass or a VNG goggle. What I sometimes do is just keep a blank A4 size paper in front of the patient's eye so that they cannot fixate. And when you look at them from the side, you can find out if they have a spontaneous nystagmus or no. And do everything, do the head shaking, the hyperventilation, do everything. Of course, it's good if you have a VNG equipment, but just the clinical examination will be enough for you to come towards your diagnosis. I can add on if I have missed something, because this is such a vast topic in itself.
Yeah, also our patients equate giddiness with a lot of non-vertigo, profiles like lightheadedness, or there may be a blackout. Right. So for many patients, chakkar means a lot of things. So we need to actually take the history in a very detailed manner. We also need to take good cognizance of their past drug history so that we know how they have treated themselves from the family physicians, from their relatives who become super doctors. And also in today's era, we must always elicit history of intake of homeopathy or Ayurvedic drugs, especially because these bhasma contain a lot of lead, and lead poisoning does lead to, neurological changes.
Okay.
And also reassurance to the patient that this is vertigo. This is not vertigo. There is still a lot of time for it.
Thank you, Doctor. Dr. Poonam wants to know what maneuver should be performed to assess vestibular system, how to differentiate in which semicircular canal problem is presented, and subjective treatment options for each.
See, the choice of maneuvers completely depends upon the demographic of the patient, basically. First, so that's the first thing. If you're having a lean personality or maybe on a heavier side, you will have to decide on the maneuver. And first is when you test the patient, test for all the three canals. Test for Dixell pike, test for McCure-Pagini, test for deep head hanging, decide the side, decide the strongest nystagmus. Based on the strongest nystagmus, decide your maneuvers. As I mentioned, there are 14 types of BPPV and there are 12 different maneuvers. So that will be based on the complete decision of that patient and the demographic of the health. You cannot perform, maybe if it is an obese patient, and with a short neck, it becomes sometimes difficult to do even a Jacobi nose. So you may have to go for short CRP techniques. There are different techniques which you'll have to do. Short CRP techniques are technique wherein the fourth stage of the Eppleys is given off. So that is how you have to treat the case. But the determination of the site, the determination of canal is very important when you're treating a case of BPPV.
Also, we need to remember there are 2 years. So patient can have 2 types of BPPV in either of the years. Bilateral BPPV, we should always keep in mind. And although anterior canal is rare, but we should always keep that possibility when we are not sure what kind of nystagmus we are looking at, especially if you don't have the Frenzel classes. Frenzel classes is the basic, instrument or that should be in your armatorium, because clinically you can diagnose BPPV accurately up to 95%. You don't need VNG or any other fancy gadget. A good clinical history, a proper clinical examination and test of vestibular function along with your cranial nerve function will give you the diagnosis is almost 98% of the cases.
Dr. Kavita, the next question is for you. If a patient is having direction-changing nystagmus after 3 days of Epley's maneuver, how to evaluate and calculate the modality of the treatment?
So if a patient is having direction-changing nystagmus, even on the first visit or even after 3 days, then it is not a case of BPPV. If you have direction-changing nystagmus, if you have alternating nystagmus, then they are all central causes. They will not be BPPVs actually.
I would like to add one more thing. If you're clinically very sound, you must understand the case at first go. Why is there, I really don't understand the term recurrent BPPV. Why the patient has to visit you 3 to 4 times in a year? If you're a very good clinician, you should be able to make it in the first 1, 2, 3 go only. Why there has to be after 6 months? See, it's only in a case of migraine that this can happen. Or as Dr. Dinesh, Dr. Dinesh and I work very closely together. Even Dr. Kavita, we are friends. So we really don't understand the concept. We are missing out on something basically. So if there's anything in doubt, please go for imaging. Please go for the battery of investigations.
Also, BPPV can exist with certain other neurological disorders, which we may not recognize clinically. So it is always better to work in tandem with a neurologist, or at least get a basic imaging done in the form of an MRI.
Dr. Dinesh, the next question is for you. If nystagmus is seen only during skew deviation test and no skew as such, and MRI shows no signs of lesion, what should be done?
If MRI shows no signs of
lesion.
Usually not central, but if you still have a clinical suspicion on the basis of you have a bilateral or a gaze-evoked nystagmus with a negative head impulse, you need not have a skew deviation for sure. You have a negative head impulse and you have a direction changing 48 hours, you should still repeat an MRI after 40 to 72 hours, because posterior circulation strokes can be missed up to 72 hours even on MRIs. So if you have a direction changing nystagmus with a negative head impulse test, you need not have a skew deviation and your MRI is normal and it is an acute event, acute or a hyperacute event, you definitely repeat an MRI after 40 to 72 hours, because for MRI in posterior circulation strokes can be negative up to 3 days time. So we have had a few cases where we had to repeat an MRI, but just on clinical suspicion, we have even thrombolized patients just with a negative head impulse and a gaze-evoked nystagmus.
Okay, thank you. And the next question for Dr. Neha, what are the precautions to add in daily life for a tinnitus patient, such as can we reduce coffee intake or?
Yeah, that's the coffee intake, and again the low salt diet, reduce the stress, have a good lifestyle modification, quite similar to what of migraine it is, and that is what has to be followed basically even for tinnitus. And if it doesn't work, you can have a tinnitus retaining therapy, and of course go through an audiogram to understand as to how things are, and that can be taken care then.
Sometimes a hearing aid can help. There may not be significant hearing loss, but if you go for a good quality multi-channel digital hearing aid and your audiologist is smart, that can sometimes help when everything else fails.
All our questions that we got from all our online previously mentioned is done. In case you wish to answer any more live questions that are coming up.
Yeah, there are only 2 questions which are left. So one is, I I will direct it one to Kavita. Kavita, can you explain the relationship between cervical spondylosis and vestibular dysfunction?
Honestly, I don't think there is much of a relation between cervical spondylosis and vestibular dysfunction. I mean,
Yeah,
at least not in my practice.
My answer is same. Okay. And sir, one question to you, since you use it quite often. So dose of piracetam. Basically, when you use it.
I use piracetam mainly in vestibular neuritis. I feel personally that it helps in recovery, but I don't have too much of obvious data on that. And I definitely use it in vertebropatellar strokes. The main thing in piracetam is the dose. The dose is pretty high if it has to be effective. It has to be at least 3.6 grams per day. 3.6 grams per day. How it works, nobody knows. It's basically an anti-glutaminergic effect. It's got an anti-glutaminergic effect. It acts on the SV2A receptor. It's a very weak SV2A receptor drug. It's like levetiracetam and the newer thing that has come, which is brivaracetam. But what is important is the dose. If it has to be effective, it has to be used 1.2 grams TID at least. The problem with long-term usage of such high doses is extreme irritability and agitation with piracetam. So in acute phases of stroke or acute phases of vestibular neuritis, I've seen it helps, but otherwise there's absolutely no use.
Yeah, I would like to ask a question to Neha, Kavita, and the neurologist. What is your observation between deranged lipid profile in patients of Meniere's disease?
Well, I have not got any correlation as yet in the case of especially Meniere's, but yes, I will always take a thyroid function test into accountability. I would take it on higher priority because right now what we practice as per the guidelines, the Meniere migraine spectrum. So we see more of migraines coming with a normal Peyotone audiometry rather than having Meniere's. And of course, the patient also with a single drug of migraine does wonders, does well. So that's my take. Dr. Kavita and Dr. Dinesh can add on to that.
Lipid profile, I haven't tried to evaluate in Meniere. That's something new to me. I'll have to read about it. I'm not sure.
Neither have I. I have also not.
There was an article in the OCNA where they found a correlation. And after reading that, in the next 27 patients of Meniere's disease that I have seen, 26 had deranged lipid profile.
So did you study them on any of the statins?
Yes. I did not start them. I referred them to a physician colleague of mine, and all of them are on rosuvastatin now because it has been reaccepted again as the safest one. And their severity of Meniere's has come down. The frequency is also less.
We will definitely try in our practice in coming days. And I would like to thank my panelists here, Dr. Vikram, Dr. Vijay, and of course to my friends and colleague, Dr. Dinesh Singh and Dr. Kavita. It is always a pleasure to have you on the AIB India platform. And of course, we'll be having many more sessions in the coming days. And over to Akanksha and Shilpi ma'am.
Yeah. Thank you so much, Dr. Dinesh, Dr. Kavita, Dr. Neha, Dr. Vijay, Dr. Khanna, for all of you and for your precious time. Last but not the least, our final presenter is from Sun Pharmaceuticals. Dr. Vijay.
Please take your seat. Thank you.
Thank you. Please.
Thank you. So I'll be discussing about the beta-histine. So this is the orally active histamine analog, and the actions are similar to the histamine, widely studied in vertigo. Of course, Dr. Neha has already, done this molecule in her brief presentation, but I'll be just taking you through the brief about this molecule. So the initial oral treatment is 8 to 16 milligram 3 times a day, taken preferably with meals, and the maintenance dose generally in the range of 24 to 48 milligram daily, and the dose should ideally not exceed 48 milligram. And this beta-histine is not recommended in children less than 18 years of age. Contraindication, and Dr. Neha has already mentioned, the pheochromocytoma. hypersensitivity to any of the active substance, and the caution is advised in the patient with the peptic ulcer, bronchial asthma, or the patient with either urticarias, rashes, or allergic rhinitis. So if we look at the pharmacokinetics, this is the peak plasma concentration is attained approximately after 1 hour. Distribution, it is less plasma protein bound, and elimination occurs through mainly by the renal excretion. So if talk about the mechanism of action, it basically stimulates the H1 receptor and blocks the H3 autoreceptors, right? So how it does, the when it blocks the H3 receptor, it increases the release of histamine, vasodilatation, and the CNS effect. Basically, it causes the cerebral vasodilatation and increase alertness and awareness, and that leads to the resolution of vertigo. So that's how the beta-histine basically acts. It blocks the H3 receptor and stimulates the H1 receptor, and that's how it stimulates the release of histamine and acts on the central effect in the brain and improves the cochlear and the cerebral blood flow. That's how the vascular effects in the inner and the inner ear and the brain. So the unique anti-vertigo and the comprehensive action, it increases the cerebellar blood flow, increases the cochlear blood flow, that normalizes the perfusion, reduces the firing rate from the vestibular reception, that leads to the control changes in the vestibular system, and enhances the vestibular compensation, that fastens the recovery. So that's how the unique anti-vertigo action. The adverse events, as Dr. Neha has already mentioned, is majorly the GI related, and even in the post-marketing surveillance data, we found that it is majorly related to the gastrointestinal disorders. So coming to the few of the important clinical evidences, so the beta-histine was tested for the effect of treatment on the postural stability in the patient with different duration of BPPV. And the observation was the beta-histine normalized the postural stability with the duration of BPPV less than 60 days after 10 days of treatment. So that was the conclusion. Then the second study is basically to understand the effect of beta-histine in addition of Epley maneuver in the posterior canal BPPV. So in this, the results was the symptoms were significantly reduced in all three patients overall, and those patients younger or the older than 50 of the age who had hypertension, the symptoms less than 1 month. So beta-histine in addition to the Epley's maneuver is more effective than the Epley's maneuver alone or in combination with the placebo. So that was the conclusion of that study. The another study where the efficacy and safety of beta-histine treatment in the patient with Meniere's disease, that is the BMED trial. So the results was the incidence of attack related to the Meniere's disease did not differ in all the three treatment group. But when compared with the placebo, the attack rates ratio was 1.03 and 1.012 with the low dose and the high dose of beta-histine. So that was the results, and the results were consistent for all the secondary outcomes as well. Another study where the effectiveness of beta-histine 48 milligram per day in the patient with the vestibular vertigo, that is the Virtuoso study, was done, where the findings suggest that the beta-histine 48 milligram per day is effective in treating vertigo in routine clinical settings. And the use of beta-histine, the multiple reviews that has been done, the clinical studies and the meta-analysis that beta-histine is effective, it demonstrates that the beta-histine is effective and safe treatment of Meniere's disease, BPPV, vestibular neuronitis, and other types of peripheral vertigo as well. So that was the overall conclusion of multiple reviews and the meta-analysis that has been conducted for the beta-histine. So that's about the beta-histine in nutshell. Thank you so much. Thank you.
Thank you, Doctor. Well, as all good things come to an end, and so does our event, I would like to Dr. So from Sun Pharmaceuticals, our BU head, Dr. Amrish Sahai, he would like to say a few words. Please come, Doctor.
It's a matter of great pride for Sun Pharma to host such a wonderful event today. I'm indeed thankful to Dr. Vikram Khanna, Dr. Neha, and Dr. Vijay Kadam for their wonderful deliberations and the questionnaire session. Doctors sitting across the geography at different part of the country, 20 centers in India, many medical colleges. I'm definitely they are going to be benefited with the deliberation and with the scientific contents of this program. On behalf of Sun Pharma, I convey my heartiest thanks for sparing your valuable time to attend this webinar. Thank you very much.
Thank you, Mr. Sahai. Yeah. Dr. Neha.
Yeah, on behalf of AIB India, I take a lot of pleasure, and I'm extremely thankful for all of you to join in. Of course, I think we are expecting there are around 1,200 plus delegates who are watching from all parts of the world, and I'm extremely happy. The role of AIB in India is to improve your clinical skills here. We are here to teach you more about the vertigo in the clinical examination. Of course, you can always have your equipments by your side, but always get your basics clear before you should be able to understand what is a central vertigo, what is a peripheral vertigo, or you lose the case within the first 3 hours or 6 hours from the start of vertigo. So I was extremely thankful to my team because it took about 3.5 months for us to prepare for this program. We were also present in MentCon, and it was a very hectic schedule for all of us, but we are very happy that the program has come. I would also like to thank my Australian panel, Professor Ian Corthois, who has made the head impulse, made our life easy to diagnose those cases. I'm extremely thankful to Dr. Mariam Velgampola, who spared out this time. At this time of the hour, she's one of the leading neurologists in the world. Dr. Raj Gopalan, an Indian-based doctor. He was very sweet, and of course, there were a lot of questions coming. I will see that they visit India next time. And of course, to my our founder, Dr. Richard Gans and Dr. Sakumara, who took out time, and the entire team of AIB India who are present, and the audience who are watching us. Thank you very much for encouraging us, and we look forward to have many more programs in coming next quarters and the next year. Thank you.
I will just take 1 more minute probably of all of us. And I would like to remind all our wonderful audience that as a sign of gratitude for all our attendees who want to enroll for the International Vestibular Rehab Course 1 and 2, you will be entitled to a special discount. We also have special discounts for neurologists, ENT surgeon, and neurologists who wish to own an AIB licensed center called as a Center of Specialty Care. You can contact us through the numbers that are displayed on the screen. You can use the code TRIWEB for exclusive discounts on our courses. And thank you so much for attending this event. Have a good night, all of you. Shubh Ratri. Thank you. Thank you so much for attending us live during this session. Our online session is closed. We have 1,200 plus attendees for this event, which is a big number. So thank you to AIB team, thank you to Sun Pharma team, and thank you to all the attendees who could visit us today. Thank you to the technical team also for managing it so well. And AdCode Arpit, thank you so much. Good night.